Hi guys, welcome back. The next topic that we're studying is ECG and arrhythmias. The objective of the discussion is to allow you to solve ECG based questions under 1 minute. It looks like a tall order at the moment, but if you listen to the inputs that I provide to you over the next couple of hours, you will definitely be in the right frame of mind to solve these questions. Let's get started. Let's dive into the wealth of the information here. And the first and the foremost thing that I want you to do is discard the decimal system. Like for example, if I ask you what is the duration of one small square in the ECG, a lot of guys have a habit of answering it in decimal system as 0.04 seconds. I would rather suggest you to remember this in round figures, that the duration of one small square is approximately 40 milliseconds. And well, how is that advantageous over a decimal system, you would come to know in the next few minutes when I speak before you. Once we are clear about the duration of the one small square, we next need to remember what is the normal duration of P wave in the ECG. You are very well familiar from physiology. It indicates atrial depolarization. The duration is going to be under 120 milliseconds. Now the advantage for you guys is that when you are serially evaluating the ECG and checking out each of the waves per se, the P wave should be ideally fitting within 3 small squares. Please remember the fact that the vertical height of the P wave should be under 2.5 millimeter in the limb leads and less than 1.5 millimeter in the chest leads. The point is, at the moment you can remember only one, and why that is important is because they have asked about abnormalities like P pulmonale. So I can mention one question straightforward here. P pulmonale will be vertical height more than 2.5 millimeter. Next, he can ask you regarding PR interval. Now, when you read the word PR interval, the impression that comes is that it is up to the R wave, but that is not the case. PR interval will be from the starting of the P wave. The name is PR interval, but please remember it will be right up to the starting of the Q wave. Well, what does PR interval signify? So it would be signifying a AV nodal conduction. And at this particular point of time, I want you to remember that PR interval is always inversely related to the heart rate. So lots of time when I'm going to be talking about a tachycardia or tachyarrhythmias, PR interval will be short. Remember the inverse relation. In bradyarrhythmias, we will always talk about a prolonged PR interval. Now, what is the normal duration of PR interval? So that would be in the range of, again, don't use decimals. That can be fraught with error. I would like you to remember in round figures, that is 120 to 200 milliseconds. So 40 was one small square per se. So mathematically speaking, PR interval of yours and mine will fit into 3 to 5 small squares. This explains the fact that whenever I'm gonna say bradyarrhythmias, you will notice that the PR interval might be going more than 5 small squares, vice versa. For tachyarrhythmias, it would be less than 3 small squares. So it's always a good idea to remember this information. The next wave that you will get will be the Q wave. Now, when it comes to Q wave, what does it indicate? So, lots of guys casually answer ventricular depolarization. Please remember, it is QRS complex that represents ventricular depolarization. It is the Q wave. Q wave mainly indicates a septal activation. And where do you check for the Q wave? Then always look at Q wave in lead number V5, V6. Why that is so is because the vector for the Q wave is actually going away from lead number V5, V6, and Q wave is a negative wave. See guys, ECG is after all a vectorial analysis, no? So this is what I'm saying. If we are going to talk about the interventricular septum getting activated, this is septal activation. With respect to the bundle of phase, we have a left fascicle, we have a right fascicle, and vector is going away from the following leads. This is lead number V5, this is lead number V6. So once the current is going away, you would definitely be in a position to identify V5, V6 will be having Q waves. I mean, it's futile on your part to look and check out the Q waves in V1, V2 where they're hardly seen. It is mainly V5, V6 where they are seen, and we'll definitely talk about conditions where we get capital Q waves as well. Now, if they ask you what is the duration of a normal Q wave, then your answer would be that this would be less than 40 milliseconds, and therefore it will fit into one small square in the ECG. In fact, I can just quickly sketch this before you so that you are able to retain this information. I said one large square will be having approximately 5 small squares, and the duration of one small square per se is 40 milliseconds. The Q wave of yours and mine will always fit into one small square, both duration wise and height wise. When you read a standard textbook, you might say depth of the Q wave is, approximately less than 25% the height of the R wave. But in the actual exam, they're not going to give you a scale by which you can actually measure. So what I want you to remember is, or the quick hack to understand is that Q wave, normally the small Q wave always fits within small square. That is both duration wise and height wise. If you are going to have a Q wave in the ECG, which is spilling out of one small square, you can very well see here I've done both. I have shown a Q wave which is going out of one small square both vertically, that is depth wise, as well as duration wise. So the technical word that I'm using now is called as deep Q wave. And as we progress in the discussion, you will study what conditions causing deep Q wave. But one I can remind you right now is myocardial infarction. Deep Q wave signifies cell death, and this finding is never ever gonna go back. I mean, in MI, when you read about the ECG findings, most of the findings will gradually begin to regress, but deep Q waves will persist for whole life of the patient. When it comes to QRS complex per se, it indicates ventricular depolarization. Obviously, the value is a range. It is in the range of 80 to 100 milliseconds. All the data that I'm telling you is always in milliseconds and round figure. And therefore, whenever you check out the QRS complex, this would be between 2 to 2.5 small squares. SS means small squares. Now, why that is important, guys, is because when I'm going to discuss regarding narrow complex tachycardia versus wide complex tachycardia, narrow complex would mean less than 2 and wide complex would mean 3 small squares. So you just need to get the data right for the small squares and your orientation gradually will start appearing. Next on the agenda would be to rather focus on the QT interval, which is mentioned lots of time in MCQs. So QT will be from the starting of the Q to the end of the T, and you can very well see that QT is including the T wave as well as the QRS complex. I want you guys to remember the fact that per se when I talk about the QT interval, it is going to be a combination of ventricular depolarization plus ventricular repolarization, because it is including T wave. T wave is for repolarization, QRS is for ventricular depolarization. What is the normal duration of the QT interval? It would be 360 to 440 milliseconds. The bottom line is that QT interval will be something in the range of 9 to 11 small squares per se. Please remember the fact that in lot of questions on electrolyte imbalance, you will notice QT will be affected. Like QT has an inverse relation with potassium and magnesium. So if I say hypokalemia, QT will be prolonged. If I say hyperkalemia, vice versa, same is the scenario for calcium and even for magnesium. But the point is QT exhibits an inverse relation when it comes to electrolytes. So a lot of questions on electrolyte imbalance will come, and that is the reason why even in lecture series you would have seen I've taken a separate lecture on ECG findings in electrolyte imbalance, because that itself is a topic which has a lot of questions that are going to come, and at the moment we're focusing on some baseline information. I basically want you at the moment to remember that these durations are important. The thought process of yours is P wave fits into 3 small squares. PR is going to be 3 to 5. Q is going to be 1. Then it's going to be QT, that's 9 to 11. And QRS is 2 to 2.5 small squares. Why these are important, why the mental impression of these is important, is because when I talk about terms like short PR, when I talk about prolonged QT, then you should be able to figure out the durations in your mind immediately, because you'll obviously have to physically count them if they want to give any kind of gross abnormality in the exam, like bradyarrhythmias per se, prolonged PR interval, you will have to do the physical counting of the small squares. Now comes an important domain. Please be very careful in what I say next. You can very well see that the end of the S wave, this particular area that I'm zooming in for you, this is what is called as the J point. It is also called as the isoelectric point. So this particular area that I'm now marking before you, that is the end of the S and the starting of the T, is the one that is called as ST segment. Well, QT is an interval and ST is a segment. Why? Because if you follow my words, QT is from the starting to the end. The English words are starting to end, start, end, start, end. That's the word I've said. But when you look at ST, where is ST starting from? It is starting from the end of S and the starting of T. I repeat once again, interval in ECG is going to be the start, end. Whereas when it comes to ST segment, it's going to be the end of the S and the starting of the T. So the words were inverted, the start and the end ones. And that is why we have terms like interval versus the segment. ST segment, you don't need to remember the duration because it's going to go up, it's going to go down. So I'm going to teach you subsequently mnemonics that will help you identify ST elevation causes versus ST depression causes. But then that would be sequentially discussed. I mean, I'll go in a sequence with respect to abnormalities of the P wave, abnormalities of the PR interval, and then subsequently I'll talk about each of these individual waves. Lots of time in the exam, they love to ask or incorporate physiology as well, which is the reason I've deliberately started not directly with the abnormalities, but rather with the waves per se. So the next question that comes up is, what is the height of the T wave? Like I taught you, the duration of the P wave was 120 millisecond and the height was less than 2.5 millimeter. For T wave, we don't consider duration. For T wave, we again follow the height per se, and T wave will follow the ST segment. If ST goes up, T will go up. If ST goes down, T will go up. So this is like, the T wave is like a smitten boyfriend. Wherever the girlfriend will go, the boyfriend will follow. So T wave is always gonna follow the ST segment. So the question is still open, guys. Can you tell me the vertical height of the T wave? T wave indicates ventricular repolarization. It is okay. Whatever I've taught you till now is taught in physiology as well. But when I ask this question, vertical height or T wave, usually I find people drawing a blank. So please remember the vertical height would be less than 5 millimeter in the limb leads. LL means limb leads. And this would be less than 10 millimeter, 10 small squares in the chest leads. And why that is important is because we're going to talk about conditions like hyperacute T waves, tall tentative. So when I say tall tentative, it has to be more than the amplitude that we're discussing. And well, that's important because we're also going to talk about conditions where there would be flattening of the T wave present. At the moment, guys, I've talked about some normal waves in the ECG, and now you can also see another aspect coming up, that is U wave. Whenever I talk about U wave, the first answer that I get from a lot of people who have studied internal medicine is, sir, U wave is found in hypokalemia. No, guys, U wave is a normal finding. In hypokalemia, you're gonna be having a prominent U wave, bigger than this one. Normal U wave is definitely encountered in ECG of yours and mine as well. And what does the U wave indicate? It indicates delayed repolarization. Alphabet R here signifies repolarization of the papillary muscles. So if ECG of a normal person is done and the heart rate is usually in the range of about, I would say, 60 to 75, because as the heart rate goes above 75, this wave is usually not visualized. But in the heart rate of 60 to 75, like in marathon runners, the vagal tone is higher, so you will be able to see U wave in ECG of normal people as well. I agree to the fact that if I change this into prominent U wave, that's definitely gonna be a feature of hypokalemia. But at this junction, I definitely want you to remember this baseline information, and let us just see whether you can recall this information quickly or not, especially with respect to the durations that I'm going to focus at the moment. I have today taught you durations of the following parameters. We talk about duration component at the moment, not the heights. P wave will fit into 3 small squares. PR interval will fit into 3 to 5 small squares. Q wave is going to be 1 small square. QRS is 2, say 2.5, and QT is going to be 9 to 11. This is the reflex that I want you to have. I mean, whenever I talk about short PR or long PR or a short QT or a long QT syndrome, you definitely should be able to work out this information. Over and above this, I've talked about the height criteria as well. P wave is normally less than 2.5 millimeter in the limb leads. I've deliberately mentioned only the limb lead criteria because that is the one that is deployed. And if the height of the P wave is more than 2.5 millimeter, that is P pulmonale. Similarly, the T wave height, as I've explained to you, should be coming under 5 and 10 millimeter respectively. And when you read tall tented T waves in hyperkalemia, you will definitely be having a height more than 10. If you read about prominent U waves, it will signify hypokalemia. So a lot of these concepts are going to come up subsequently. But if you just tend to get an orientation into the aspects that I said right now, the baseline information that are revised from physiology before you, you are definitely on the track to learning much more technical aspects and be able to solve these questions in a limited time frame. That's what actually happens in the exam. It's a pressure cooker situation. So definitely our mind has to be very focused while solving a ECG based question. And believe me, guys, they're very easy. These technicians or nurses know who are working in the intensive care for a few years. They are able to analyze ECGs better than interns. Why? Because they are seeing this regularly. See, this is only a skill. When you see a mathematical graph, half the doctors tend to get nervous because we doctors are usually not good at mathematics and graph representation, etc. The point is, when you see something on a regular basis, then it becomes a second nature to you. So there's no big deal, guys. It's a very easy topic, very scoring topic. It is just that we need to get used to it. You know, when you regularly do 4-5 questions of ECG daily, then after 10 days, see your approach and try to do all of them in one day. I mean, if you're trying to do 50 questions of ECG in one day, कि भाई आज खत्म करके छोड़ूंगा, then the point is it will lead to frustration. So spread it out. I mean, this topic should definitely be spread out, especially when it comes to doing questions. And the first 5 seconds, guys, whenever you are analyzing a ECG, you have to check out the heart rate. So next I'm gonna focus on how do you analyze the heart rate of the ECG per se. Please remember, heart rate is the only topic in ECG where I'll ask you to count the large squares. I'm going to highlight this word here. Everything else that I'm going to teach you in the ECG right now in part 1, in part 2, everything is going to be small square duration. Only in heart rate, it is the large squares which are to be counted. And well, how do you determine the ventricular rate per se, guys? So that's going to be the distance between the R and the R waves, which we are going to call as RR interval. Now let's look at a couple of examples here. If I scroll through the first diagram, I definitely can notice about 6 large squares, approximately 6. It could be 5.8 approximately, but 6 large squares to make it easier for us mathematically separating the R and the R. But if I move inferiorly, then the number of large squares has dramatically changed to 5. I mean, I'm not here to teach you mathematics, but what I'm trying to sensitize you to the fact is that when you are seeing any ECG, you should first look at lead number 2 right at the bottom of a 12 lead ECG, that is rhythm strip. You see, lead 2 is given twice in the ECG. One is lead 1 to 3 recording, AVL, AVF, and AVR, then V1 to V6, and then at the bottom, lead 2 is running. So, heart rate should always be calculated in lead number 2. The formula that you're going to deploy is 300 divided by the number of large squares. Mark my words there. It is 300 divided by the number of large squares that are separating the R and the R wave. Like in the first one, you can see that it's approximately 6. So 300 by 6 is what mathematically will turn out to be 50. So the person is having a bradyarrhythmia or at least a bradycardia. We'll find out subsequently what kind of bradyarrhythmias are present. In the next ECG that I've highlighted before you, the heart rate is coming down to the lower limit of physiology, maybe a hypothyroidism patient hitting 60. But this is going to be the value for you and me. That is approximately, I'll put it at 75. And now we're going towards the tachycardia range. I mean, I want to highlight, I'm not teaching you any kind of mathematics. I just want you to be very comfortable with these values. Why? You will see the importance immediately. The moment you find less than 3 large squares, mark my words there guys, the moment you find less than 3 large squares separating R and R, there's definitely a tachycardia in the patient. This would be 300 divided by 2, 150. And as you progress further, let's say this is a PSVT occurring in the patient actually, and the heart rate of this patient is approximately 300 divided by 1.5. Give and take a few small squares just for calculation purposes. You can see the heart rate jumping up to as much as 200. So my point is, what you need to understand, the carry home message is, if you find less than 3 large squares separating R and R, and if you find more than 5 large squares separating R and R, there's a lot of difference. If it is less than 3 large squares, the RR interval, then there is definitely a tachycardia occurring in the patient. Whereas if it is going to be more than 5, then the heart rate is going to be less than 60. You see, normal physiology values you are anyway familiar with. I just want you to remember the number 35. If in any ECG you find RR interval is going to be having less than 3 large square, there's a tachyarrhythmia or at least a tachycardia happening. I mean, tachyarrhythmia we'll learn subsequently. And if it's going to be more than 5 large squares, we're definitely having a bradycardia present. And that should be right in the first 5 seconds of the ECG. And then subsequently, the next 5 seconds are to be invested for axis calculation. So now I'm going to teach you how to evaluate the axis. We'll go stepwise, 5 seconds for each step. It's heart rate, it is axis. Then we look at P wave, we look at the height and the duration. Then subsequently, whether P wave is followed by QRS complex. Is there a normal sinus rhythm? Is there a drop beat present in a patient? So that comes with practice. But the first 10-second roadmap is mainly clear before you. Check out the heart rate at least twice, because I'm going to teach you conditions where they're going to be irregular RR interval. If you miss this point, I'm going to say this again, guys. Don't check RR interval only once, because lots of time there could be a ECG of atrial fibrillation and multifocal atrial tachycardia where RR interval will be changing. If RR interval will change, no, you just can't say by counting only one time, okay, this is the heart rate, because it is variable. And two arrhythmias where we get a irregular pulse per se. I'm highlighting the question right away. I mean, it could be 3-liner, 4-liner. The keyword is irregular pulse. 2 times you're going to read it: atrial fibrillation and multifocal atrial tachycardia. So lots of time, you just by counting and evaluating, you know that you narrow down to 2 differential diagnoses, and then subsequently you will come to realize that in atrial fibrillation there are no P waves. In multifocal atrial tachycardia there are variable morphologies of P waves. So if I get a ECG in the exam in which there is a irregular heart rate, if P wave is absent, it is atrial fibrillation. If P wave is present, I'll straightforward answer it as multifocal atrial tachycardia. I'll not even try to look at the variable amplitude of the P waves per se. So the message here is that all of these steps are important. Don't just think that we are doing mathematics here, guys. Each of the steps that we're discussing do have their diagnostic relevance. They have their diagnostic importance as well. When it comes to axis calculation, the normal value should be remembered as anything between -30 to +110, and I'll just teach you how to analyze it. At the moment, the message is that if a person is having left axis deviation, that would mean value less than -30, then it signifies that the left side of the heart is exhibiting an enlargement. Example could be like ostium primum variety of ASD. On the other hand, when you read about right axis deviation, it means that the right side of the heart is showing a significant enlargement. Example can be like a case of COPD. So the main advantage of determining the axis is to determine which side of the heart is under strain or which side of the heart is actually becoming bigger in size. Now to calculate this, all you need to do is mentally visualize a graph like this, where I've shown lead number 1 on the x-axis and lead number AVF on the y-axis. Next step is important. I'll be just plotting positive and negative here, and the word of caution is that on the x-axis positive is on the right, negative is on the left, no issues. But mathematically, if you look at the y-axis, the one that you studied in class 10th or 12th, y-axis, it is this area where I'm putting negative sign. This should be positive, but it is opposite, it is ulta in ECG. AVF positive is inferiorly located, negative terminal is superiorly located, and all you need to do now is look at the height of the R and from that subtract the depth of the S. I don't need to count the actual number of squares. You can actually notice here the fact that the height of the R is more than that of the S, so the vector will be positive. If you look at AVF again, you will notice that the height of the R is much more than the depth of the S. In fact, S is almost non-existent. So what I can see is the vector is positive for both of them. Now, just like when we were in class 10th or 12th, we used to do vector analysis. Similarly here, I've just plotted the positive and the positive here, and you can notice that the axis is following in the following quadrant. I want you to remember that if the axis falls in this particular area that I've highlighted, that is -32 plus 110, then this would be called as normal axis. Our objective would be to now talk about situations where we can be having left axis deviation, right axis deviation, and even extreme axis deviation. So let us compare this particular ECG with the subsequent one which is currently shown. In fact, one of the highlights of this ECG is, and that's itself a question, it is showing a broad QRS complex tachycardia. Why am I saying a tachycardia at the moment is because if you calculate the RR interval in this patient, it would be approximately, even if how casual you are, I can say it is approximately 1.5 large square. So mathematically speaking, 300 divided by 1.5 is a huge increment on the load on the heart. Especially the oxygen consumption is dramatically going to jump up if the heart rate of a person is going to reach about 200. This person is actually having a ventricular tachycardia. In fact, broad QRS tachycardia first differential diagnosis is always a VT. In the subsequent discussion, I will teach you regarding what are the other criteria for diagnosis of VT. But at this juncture, my main focus is not on the diagnosis on the tachyarrhythmia part. My main focus is on the calculation of the axis. So let's do the same activity. Lead 1 on the x-axis and lead number AVF on the y-axis, and we just need to look at some very interesting data. In fact, this I would rate as the most important part from the axis calculation part. You see, if you look at or scan through the ECG of this patient, anything that goes down is obviously the negative wave, that is the S wave. So if you look at the negative wave, the depth of the negative wave is much more as compared to the height of this slurred R wave. If you look at the vector here, anything that goes up is R, anything that comes down is S. The depth of the S is much more than that of R. So in lead number AVF, if I just go mathematically, R minus S will turn out to be negative. Why? Because the depth of S is more. You see, this is the baseline that I'm talking about. The R wave, which is a positive wave, it's slurred because of intermyocyte conduction, that you will be more comfortable in the subsequent part of the discussion when I talk about VT. But at this junction, you can very well notice as compared to the baseline, the depth of the S is much more as compared to that of R. That is why I have put a negative vector here. Let's look at what's going on in lead number 1. Again, the same story. The positive, which I'll highlight with a different color, that is R wave. And if you compare with the depth of the S, huge disparity, no? So again, the result is going to be R minus S will turn out to be negative. I can actually count the number of small squares, but it is a futile exercise. No, after all, I just want to see what is the average vector per se. It's turning out to be negative. So let's just plot this. I had taught you the fact that this is how we take positive, negative on X and Y axis for AVF. Now all I'm gonna do is plot this negative, join the two, and I'm gonna be having a vector which is totally opposite of the quadrant that I was talking about initially. This is when I was saying normal axis, but now you can very well see that the axis is totally, or the direction of the vector is totally opposite, or is in a different quadrant from what I drawn earlier. So this would be the one that is called as extreme axis deviation, and this is itself an MCQ. No, extreme axis deviation can be seen in the answer would be this tachyarrhythmia that I spoke, ventricular tachycardia. At the moment, even if you don't remember that VT has extreme axis deviation, no problem. I just want you to have the capacity to have a quick look at the heart rate and then evaluate the axis within 10 seconds. And believe me, it looks easier said than done, because when we do mathematics or positive versus negative, I've seen people messing up. And here I was still having the flexibility of actually drawing it. No, in exam you won't be actually be able to draw it. So I would suggest you that when I'm drawing this X and Y axis for 1 and AVF, try to draw with me so that you get a reflex for it. I know it is very simple, but in the exam in pressure cooker situation, I've seen people actually messing up. So let's practice this once again so that you are thorough with the inputs that I'm providing to you with respect to axis calculation. Lead 1 and AVF have been plotted. Now I'm going to do the same activity for the second last time. You can notice that the height of the R is much more. S is almost non-existent. So lead number 1, the vector is definitely going to be turning out to be positive. No issues with that. Let's look at AVF. If I just zoom it in slightly, you will notice that the depth of the S is slightly more as compared to R. So in lead number AVF, the vector is turning out to be negative. Now in the exam you will have to plot it mentally here, so you are anyway getting inputs from my side, but in the exam you have to just plot it the way I've said. Lead 1 is positive, but lead number AVF is negative. So if you plot it, this is how the axis is going to be looking. In contrast to normal axis, which was -32 plus 110, you can notice that now the axis of the vector is lying in the superior quadrant, above and above, I would say, the normal quadrant per se. So this is the one that is technically called as left axis deviation. It signifies left chamber enlargement. Let's do it once more. This time for this extreme right diagram, I've just plotted lead 1 and AVF respectively. This time I'm not going to mention positive negative, just to make you used to the fact that in the exam or when you're doing it mentally, there is no need for putting any positive negative. If you look at lead number 1, you can very well clearly notice only that is decipherable is a significant S. R is very negligible. So in lead number 1, the vector for R minus S is turning out to be negative. Now when we move on to the next diagram, we are gonna once again plot lead number 1 and AVF respectively. You can notice that in lead number 1 per se, S is significant, but R is very small. So the vector analysis of R minus S will turn out to be negative. If you look at AVF, you will notice that R minus S will turn out to be positive. So let's just quickly plot it, guys. I said 1 is negative, and when it comes to AVF, it is positive. And if I join the two, the vector is going to be dramatically, or I would say significantly distant from what I had mentioned earlier. The normal range was what I said in or represented in color green, -32 plus 110. This is turning out to be fairly away. So I agree that nowadays we have computerized systems and we don't need to actually bother with all this. But because this is given in the protocol, in the textbook, so it is my job to actually sensitize you to how do we do this basic activity. At this juncture, I have tried to explain to you regarding calculation normal axis versus extreme axis deviation. In fact, they're very easy. Normal axis and extreme axis, both are going to be positive, and negative. So it is highly unlikely that in the exam, they are going to give you a ECG of either a normal or extreme axis deviation, because it is easy to calculate. And anyway, most people have read this information of extreme axis deviation in ventricular tachycardia. So most people even do not bother to, do this vector analysis. They see a VT and they say, okay, fine, man, this is extreme axis deviation. Most of the time in the exam, if he's going to give you axis deviation, it's going to be these two particular ECGs that I've highlighted. So I would request you to kindly, if you have missed it, just go back in the video and just try to do this vector analysis at least once by yourself so that you're more comfortable with it. And once you've done this, we are through to the 10-second interval. We now go from 10 to 15-second analysis interval where we will check for the abnormalities of the P wave. I repeat once again, first 5 seconds the heart rate, next 5 seconds axis, next 5 seconds the P wave abnormalities is what we're gonna focus on. And if you look at the configuration of the P wave, which is going to originate from the SA node, the initial part of the depolarization or the initial part of this upright wave indicates the right atrial depolarization. And when you are looking at the downswing of it, it is representing left atrial depolarization. P wave per se is a upright wave. Height and duration has already been mentioned, that is less than 120 milliseconds for the duration, less than 2.5 millimeter for the vertical height. P wave is positive everywhere except one. If you look at P wave with respect to AVR, you will always notice that in lead number AVR per se, the P wave will turn out to be negative. I want to repeat the fact once again. AVR is one lead where the first wave of the ECG and the last wave of the ECG, the P and the T wave, both are turning out to be negative. This is perfectly normal, guys, no abnormality. AVR tends to read the heart that way, that P and T are always negative. In contrast, if you are ever gonna look at lead number V1 per se and you're gonna scan the P wave, you will notice it will be biphasic. Some part of it will be above the baseline, some part will be below the baseline. The part above the baseline is right atrial depolarization. The part below the baseline is left atrial depolarization. So the message at this junction is that P wave is always an upright wave but can be negative with respect to AVR and can be biphasic with respect to V1. And now we will look at an abnormality. The abnormality is that the P wave of the patient is turning out to be rather wider than what is supposed to be. Why? Because the person is having a left atrial enlargement. I have drawn a P wave with a slight notch. Now this notch may not be visible in the actual exam because lots of time the ink blots on the paper, so the notch may not be very classical textbook kinds. But what you can definitely see in the ECG of this patient is a duration of more than 120 milliseconds. If the duration of the P wave is more than 120 milliseconds, that is about 3 small squares or more, then it is technically called as P mitral. Well, what does P mitral signify? It signifies that the left atria of the patient is dilated, so the current will take more time to go across this dilated left atria, and that is why they usually ask you P mitral signifies. You just need to answer LAE, that is left atrial enlargement. In contrast, in some cases, they might even give you a ECG where the height of the P wave will be dramatically increased over and above normal. So if the P wave vertical height is more than 2.5 millimeter, we call it P pulmonale. It signifies right atrial enlargement and is commonly seen with patients of pulmonary artery hypertension. So at the moment, I want you to remember two abnormalities of the P wave that I'm going to now show you in real time. You can notice a slight, I would say, a bifid appearance of the P wave coming up. Actually, the point is this is the classical textbook image, so fine. It might look to you that you can see the notch per se, but what I want to highlight here is the fact that lots of time in the exam, all you will notice is that it is the duration component which is going to be hampered in this particular case, and at the same time the P wave amplitude, it's rather spiked P wave. No, I mean I'll say P wave has more of a rounded configuration. You can notice the spike occurring in the P wave. That's because the height is relatively more. So the superior representation that I made before you is for P mitral and the inferior one is for P pulmonale, and these are two abnormalities just must be always looked at. And following the P wave, always check out whether QRS complex is present or not, because if it is present, it is normal sinus rhythm. If not, then there could be a possibility of heart blocks occurring in a person. I'll describe the heart block subsequently when I talk about the PR interval, because coming up next is PR. Either PR can be short, therefore there could be tachycardias in a patient. If PR is prolonged, there would be bradyarrhythmias occurring in a person. So the objective at this particular point, the where we stand at this particular point is, we have learned the roadmap for the first 15 seconds of analyzing a ECG, the heart rate, the axis and the P wave duration, and check out whether P is followed by a QRS complex or not. And next I'm going to talk to you regarding short PR interval conditions versus a broad PR, or rather a wide PR interval or a prolonged PR interval conditions. The next condition that I'll be explaining to you will be having a short PR interval. Let us understand why. You see, the current always goes from SA node to AV node, goes across the two sides of the AV node, but AV node exhibits a very slow conduction. That is why in physiology you will read always the word written AV nodal delay. In fact, I would like to highlight that about 0.1 second is wasted when trying to navigate across the two sides of the AV node. Then the current will hit the bundle of his and cause a septal activation. Then it will go across the left fascicle, then about the right fascicle. The reason being, right fascicle has a higher refractory period. And then it goes via the Purkinje fibers, which are actually modified muscle fibers. And the current goes from inside to outside and causes the depolarization. And the repolarization current will be flowing from outside to inside and is responsible for the T wave. Now the problem in this particular patient that I'm going to show before you is an accessory bypass pathway. The way I've shown the red fiber, I want to highlight that it is bypassing the AV node. Remember, AV node is like a broken Indian road, and the red fiber that I've shown before you is like an express highway. So the current will preferentially tend to go across this express highway and will cause a early activation of the ventricles. The topic that I'm teaching you guys is called as pre-excitation syndrome, or is alternatively called as Wolff-Parkinson-White syndrome. The first and the foremost problem of this person is ventricles are getting excited earlier than normal. And when I say that, the query from a lot of doctors is that, sir, what is the problem with the ventricles are getting excited early? It should be good now. The point is, if you have an early excitation, then ventricles did not get sufficient time to relax. So they will not be properly filled with blood. If you cause an early activation, the ventricle will contract partially filled because it did not get time to properly get filled with blood. And because of this contraction of partially filled ventricle, there will be a decreased cardiac output. In this patient of Wolff-Parkinson-White syndrome, the red fiber that has been denoted or highlighted here is called as bundle of Kant. It bypasses the AV node. The bad news is pre-excitation syndrome causes a contraction of the ventricle, true, but it will be a premature contraction without getting filled with blood, or I can say the word early contraction. The message is these patients will be having recurrent syncopal attacks. The contraction of, or which is a premature contraction of a partially filled ventricle. I want you to focus on the statement that I've highlighted at least twice, because this is the crux of this discussion. In fact, two conditions that I'm going to explain to you in the next 10 minutes or so will mainly focus on this statement of mine. Premature contraction of partially filled ventricle, which explains the relatively less stroke volume, which explains the relatively low cardiac output of these patients. The reason why this person will come to me is that he says that while sitting on a chair, even from a very young age, he feels as if his heart is pounding in his chest. If he's a little educated, he might use the word palpitations. And for this, he had gone even to a psychiatrist who told him to take some anti-anxiety medication, but there is no relief. He says, sir, there have been instances when I was trying to maybe play with my friends. I'm not going to talk about sudden cardiac death in this case, guys. Sudden cardiac death, yes, can occur in this condition while playing football, no doubt about it. But what I'm saying is, he says, sir, when I was playing football with my friends, or when I was trying to do any kind of activity, something as simple as dancing at a marriage party, I became unconscious and my friends always make fun of me or say that I am physically weak and not able to match their stamina. If he gives me a family history of sudden cardiac death, it is all the way more important, because Wolff-Parkinson-White syndrome definitely has a genetic pattern, or has a very characteristic genetic pattern of inheritance. So family history of sudden cardiac death has also been discussed in HOCM. So I'm not saying that you need to put too much of importance to that statement, but over and above this, what you need to analyze in the question is, because he's talking about palpitations, recurrent syncopal attacks, it could be not a HOCM question, it could be Wolff-Parkinson-White, because when he gives you a history, there's a possibility that examiner knows the fact that you know about sudden cardiac death in a football game, so he might try to actually make you fall into the trap of answering it as HOCM or HCM per se, whereas the question will be that of Wolff-Parkinson-White syndrome. I will now explain to you how in the ECG will you analyze that this is Wolff-Parkinson-White syndrome. One of the important concepts that I'm now saying is that yes, the ventricles will get excited early, as you can see from the red fiber which is causing a early activation. But once the current will enter in the muscles, mark my words there, once the current will enter in the muscles, then it will not spread via Purkinje. If the current has to spread by the Purkinje system, it has to follow the normal pathway, the SA node, AV node, bundle of His, then it enters into Purkinje. Now, what is happening in the heart of this patient is technically called as intermyocyte conduction. And the importance of knowing this intermyocyte conduction is that intermyocyte conduction will be slower than the Purkinje. Remember, the physiology guy would have always said fastest conduction fiber in the heart, Purkinje. Everything else is slower than Purkinje. Therefore, intermyocyte conduction, because it will be slower, inside the ventricles, the current will be flowing relatively slower, so the QRS complex duration will be affected in these patients. Because I'm using the word intermyocyte conduction is slower, so the QRS complex will tend to become relatively broader in this condition. The message is, in these patients, because there is going to be a fast conduction via the SA node directly to the ventricles, therefore PR interval may be shorter. The reason for reduction in the PR interval is the fast conduction with respect to what I've shown in color red, but inside the ventricles per se, the current will spread relatively slow. I want to highlight this once again, guys, because most people say, sir, on one hand you're saying fast, other hand you're saying so. So please appreciate the perspective. When I say bundle of Kant, it's going to cause a earlier activation of ventricles, but when it comes to ventricles per se, the current inside the ventricle muscle will be spreading relatively slower. So let's just make sense of this from the ECG perspective. What I have highlighted before you at the moment is perfectly normal. I've just tried to make it a little more broader than what it normally is, for me to be able to explain to you the various intervals and durations. You see, the starting of the P to the starting of the Q wave is called as PR interval. Now I'm gonna put a green point at this particular area. This is the isoelectric point and is called as the J point. The distance between the red point and the green point. The second red point and the green point is called as QRS complex. And if I join the two together, PR plus QRS complex, then it will become PJ interval. First, we look at the mathematics behind it. PJ interval is a combo of PR plus QRS. That's the first message. Now, let's look at what actually happens in these patients. Because he was complaining of palpitations, I have already told you the fact PR interval is always going to exhibit an inverse relation with heart rate. There are two reasons why I'm saying PR in this person is short. One, I said bundle of Kent will conduct very fast, so therefore PR is shorter. Second, tachycardia will contribute to short PR interval. So message number one for the ECG of this patient is short PR interval will always be noticed. I've told you the duration, no, 120 to 200 milliseconds. In this case, it will be less than 120 milliseconds. The reason for short PR interval is first and primarily due to fast conduction, ultra fast conduction that occurs via Kant, and that is why this guy was misdiagnosed as a case of anxiety neurosis. The second thing is very important from the exam perspective because in this person's ECG, Q wave will not be seen. I have taught you the fact that Q wave occurs due to septal activation, but look at the path of the current in the heart of this guy. The current is going to bypass the AV node. It is not going to go in the bundle of phase. It is directly going in the ventricles. Now, since the current is directly going in the ventricles of the patient, as a result of it, there is a technical term used that is pre-excitation. And I will like to mention the fact that the Q wave in the ECG of this person will be absent. In which lead do you check for the Q wave? Remember in the starting I mentioned V5, V6. In this particular case, the Q wave is going to be characteristically absent. Now, let me just draw the normal QRS complex before you. I've just exaggerated the QR and the S. In this person's ECG, there's going to be no Q wave present. And when you look at the R wave, you will notice that there will be a slight change in the slope in the upswing of the R wave. I'll just zoom it in for your convenience. What I am saying is R wave in you and me will have a smooth upswing, but if you see in this particular case, there's a slight change in the slope, and that's the key word of this entire discussion. This is the reason why I'm discussing this topic with you. This is what is called as a delta wave and is one of the classical features that is always asked for Wolff-Parkinson-White syndrome. In fact, when I started this topic, the ECG that I brought to your notice was, and now I hope it will make relatively more sense, you can notice the movement, the piece finishing, there's no Q, there's no PR interval per se that can be visualized in this case. Immediately you are noticing there is an upswing of the R with the change in the slope of the R wave. This that is highlighted here is called as the delta wave. The learning for us is that whenever we're gonna read about a young guy having possibility of palpitation, syncopal attacks and sudden cardiac death with respect to maybe his sibling, brother or sister, don't only think in terms of HOCM, keep your horizons broader, and it could be a question of Wolff-Parkinson-White syndrome also. And why that is important is if he will ask you the treatment here, the treatment will be different from that of HOCM. We are not going to deploy a ICID in this case. We are not going to go for myomectomy in this case. We're not going to give propranolol for this case. In fact, for this particular person, if I want him to be normal, I have to realize there are two conduction systems in the heart of this guy, the normal one, the abnormal one. If I destroy the abnormal one, if I do a radio frequency ablation, I will be able to cure this patient for once and for all. So when I focus on the aspects related to the ECG of this person, I have highlighted before you that the RS complex, I'm calling it RS because there is no Q, will be relatively broader. Now, why is it broad? One, this change in the slope will contribute to slight broadness. The second reason for the broadness here is intermyocyte conduction. Remember, I said the concept of physiology. Intermyocyte conduction is slower than any other conduction fiber in the heart. In a sense that Purkinje is the fastest one, so this has to be relatively slower. So when I say slower, it will be broad. And now mathematics comes, guys. Give me undivided attention on the board, please. I said the PR interval of this case will become relatively short. The Q will become absent and RS will become relatively broad. So if I say mathematically the reduction of PR, listen to the words carefully, the reduction of PR is equal to the prolongation of QRS or slash RS complex. If PR is short, RS is broad, both mathematically equal, then the PJ interval will remain unchanged in this condition. One of the important diagnostic criteria for diagnosis of WPW is PJ interval is going to be perfectly normal. In fact, they can give you a ECG, they can give you a history based on this. So I would definitely like like to rate this as one of the important topics that you are understanding today, that when it comes to WPW, there are two problems in the patient. The excitation occurs ventricle wise earlier, but when it comes to ventricles firing by themselves, there might be a relative delay. There might even be a bundle punch morphology coming up because there's an intermyocyte conduction present in this guy. Now let us look at what will we do for management of this condition. So this is how he asked the MCQ. He wrote the word AP. AP means accessory pathway. See, there are two conduction systems in the heart of this guy, no? Normal one and the abnormal one. So the question said AP, accessory pathway mediated tachycardia. And he said that this person is having a syncopal episode or near syncopal episode. What will be the management of this person? He has been referred to you from, let me say, psychiatry department. Heart rate is going up to, let me say, 150, and he's saying, sir, I just feel as if I'll die, and I'm having this findings of pre-syncope as well. I feel as if I'll become unconscious. That's the description. People will roll their finger like this to say that my head is spinning. Well, you'll secure a IV line and give a drug to this patient, which will force the current to actually now go via the normal circuit. You see, procainamide is the emergency drug for this condition because it slows the conduction by bundle of Kent. If you put on the brakes in bundle of Kent, the current will have to go via the normal pathway. However, if he asks you what is the best drug for prevention of such episodes in future, then I will have to put this person on an oral medication, that is flecainide. Please remember, in emergency scenario, it is procainamide. For prevention of episodes, it is flecainide. And over and above this, if he says what is the treatment of choice for this genetic condition, which can be autosomal dominant, then it is radio frequency ablation. I mean, I'm simply saying I'm going to fry up the abnormal electrical circuit, and therefore the current will be forced to go by the normal pathway and will cause normal lifestyle to develop in this patient. Most of the time, this question is asked to actually check for the treatment of choice, because as I've highlighted, in cardiomyopathies, it is implantable cardioverter defibrillator or cardiac transplantation if feasible, let me say for DCM. But in this case, the abnormal pathway can be burnt, fried. Those are casual terms that I'm using. The technical word is radio frequency ablation. And just to see whether you've understood me or not, I'm going to draw this diagram once again of normal and abnormal circuit. And please be patient while I sketch before you, and then tell me the difference between this diagram that I'm now making before you and the one that I made earlier. At the moment, so far so good. Septal activation, current goes to left fascicle, right fascicle. This is Purkinje, very fast conduction, and we can be having contraction of the myocardium because the current will be able to go via this electrical circuit. Everything is normal at the moment. Now I'm going to show a short circuit. The current is going to bypass the AV node once again. See, AV node is relatively slow conducting. AV node always exhibits what is called as AV nodal delay, which will be a delay of approximately 0.1 second. In our case, the current of the SA node will definitely be able to bypass this ultra slow conducting pathway. This is the express highway that I'm talking about, which will directly cause activation of bundle of hairs, will cause a septal activation, will cause the current to go to left fascicle, right fascicle, will utilize the Purkinje fiber. See, if you compare this diagram with the previous one for WPW, you will notice that in WPW, the conduction system of the heart Purkinje was not being utilized. But in the current sketch that I made before you, there is a very characteristic utilization of the normal conduction pathway. Agreed that there is a short circuit in the heart, but ultimately Purkinje is still being utilized. The condition that I'm discussing at this moment, and I'm very sure you would have guessed the answer by now, is called as Lown-Ganong-Levine syndrome. Well, when it comes to Lown-Ganong-Levine syndrome, will you be having a Q wave? Yes, because septal activation is occurring in this case. What will be the duration of QRS complex in this condition? It will be normal or will be lesser, but can never be prolonged. In the previous case of WPW, why it was prolonged was because Purkinje was not being utilized, intermyocyte conduction was happening. No, now it makes more sense. But in contrast, this particular patient, he is going to utilize the normal conduction system, whatever God has given. So let's look at the problem again with this pre-excitation syndrome. I mean, this term itself results in first impression coming to a person's mind is, if you say early excitation, what is the problem? But as I explained, there would be a early contraction of a partially filled ventricle. So the cardiac output of these patients' stroke volume will anyway be lesser even while sitting on a chair. Forget about any kind of strenuous activity. So I have this individual who's today deliberately hiding the symptoms of palpitations and recurrent syncopal attacks. Why? Because he's applying for a government job. Let me say he's applied for sub-inspector job in Delhi police, or let me say he wants to be a pilot, or any kind of job where physical fitness is required, even if he wants to be a commercial pilot. He is hiding this history of palpitations, recurrent syncopal attacks, and most of the time when a person applies for a government job, he has to declare the health of his family members. If you have ever applied for a medical officer job, you will notice they give you a performa. In that you have to actually fill up, health of brother, father, mother, sister, everybody. And if somebody, writes by himself that his brother or sister had died, the doctor on the medical board immediately knows that you need to be evaluated, or the person needs to be evaluated because he's before he's selected for a government job. The message here is family history of sudden cardiac death was present in this person, but the patient of LGL is deliberately concealing his history. My capacity should be such that even if a person does not tell me the history, I should still be able to solve and analyze, is this person having some problem with his heart? I had taught you PR interval and QRS complex together make PJ interval. In this particular case, because there is a short circuit happening in the heart, so the PR interval of this patient will be shorter. But the QRS duration will be normal because normal conduction system is being used. So what is going to happen to PJ, guys? PJ will be short. If you're listening to me carefully, you would notice in WPW PJ was normal, but now I'm teaching you PJ is relatively lesser. Just for the sake of completion, I want you to remember when it comes to short PR interval, you can declare a guy medically unfit or at least subjected to specialist evaluation. Why? Because when it comes to a person with a short PR interval, he could be having this short circuits in the heart which are causing a early excitation. Even if somebody is hiding the history, you can at least temporarily make a person medically unfit, especially in those jobs where physical stamina is required. Even if I say doctor's job, no, if you're working in a COVID ward, you're working those shifts, a person has to be on his feet for all the time. If somebody is having these defects in his heart, he will not be able to handle the stress. The message here is whenever you read about short PR interval, Q wave will be present, QRS duration will be normal, and the PJ of this person is relatively short. It is suggestive of, and obviously we can do electrophysiological studies to confirm it, it is suggestive of Longin-Levine syndrome. Mostly in the exam, they ask you the comparison of the ECG findings between the two, so I will do that activity too, but if you can just write those ECG findings in comparison, majority of your work is done. Now let us look at what is gonna be the treatment for this condition. In the MCQ for LGL, he will write AP pathway, accessory pathway mediated tachycardia. In those circumstances, you will still be answering IV procainamide. Today, I've taught you procainamide as a drug of choice for two cardiac conditions which are having a pre-excitation syndrome, WPW and LGL. If he says, how would you prevent such episodes in future? Because every time he thinks that he's having a panic attack, he's rushing to a psychiatrist. The psychiatrist is loading up with benzodiazepines and other drugs, whereas this guy is not responding to that medication. So to prevent such medication, you will be recommending oral flecainide for these patients, but the day he will miss the medication, again the manifestations will occur. So I need to find a permanent cure, and the permanent cure for this person of Longin-Levine syndrome would be to undertake a RFA, a radiofrequency ablation. So 2 times radiofrequency ablation is the treatment of choice, WPW and Longin-Levine syndrome. Just to see whether you've understood me or not, I'm just gonna give you a quick overview. We'll try to analyze the two diseases under, let me say, 30 seconds to 45 minutes. WPW versus LGL. One of the highlights of WPW is presence of bundle of Kent. While I'm writing it, guys, please tell me if you have a knowledge of basic anatomy / embryology. What is the abnormal pathway in LGL called as? When it comes to Longin-Levine syndrome, no, I also drew abnormal pathway, which was shown in color green. And this is the one that is going to be definitely causing problems for the patient. So the word used to describe these is called as James fibers. So sometimes they might even use Mahem fibers. In fact, there are two different ones, but I just want you to remember that bundle of Kent is specific for WPW and James fiber and Mahem fibers are specific for LGL. Then WPW will always be having a very characteristic delta wave present. And most importantly, when it comes to the RS complex of these patients, it will be relatively broad. I want to highlight this fact. Whenever there's going to be antigrade, that is forward conduction via the short circuit, there's going to be broad RS complex. There's going to be no delta wave. On this case, it is only the PR that is short and PJ that will be short. But on the left hand side, the PJ interval will turn out to be normal. Why? Because mathematics, no, PR was short, RS was broad, both were balancing each other. For both of these conditions, we are going to be using procainamide. Now maybe I breached that 1 minute barrier that I was trying to say, but because I have to write and speak, so that is why. Otherwise, your thought process has to be crystal clear. This is the emergency drug to be used. if they both are to be answered carefully, no, otherwise people get confused, sir, what should I answer if it is an emergency situation, like he says so-called panic attack, and he's saying, sir, I am feeling so dizzy, I'll just fall down, or actually fell down a flight of stairs, luckily there's a bump on the forehead, no severe CNS bleeding, I don't want him to fall again when he goes out of my clinic again. So to prevent this from happening, it is flecainide, and then I'll be subjecting this patient to radio frequency ablation. And while I'm writing this data down before you guys, I just wanna share a personal experience. I was once taking a class in Lucknow. Brilliant guys from KGMC, and one doctor walked up to me after the class, a face-to-face one, and he told me that from a very young age, when he was preparing for his PMT, he has been complaining of palpitations and recurrent syncopal attacks. He was the only child of doctor parents, right? Parents were also doctor, and he told me that he has been to various psychiatrists, etc., but there is no improvement. So I casually told him, let's get a ECG done. And surprisingly, why I'm telling you this is a person from a doctor's family, he himself a doctor, right? I mean, final year, going on to be intern, attending a medicine class. He has been suffering from palpitations for that long, and he was neglecting his health. Most of us doctors neglect our health and do not see a doctor, or do not go, and we think it's kind of a stigma, no, theek to hai, everything is going fine. And the ECG of this guy showed very characteristic delta waves. Now the ECG showed delta waves, so obviously I had to suggest him to go for radio frequency ablation, and he, after that, obviously his episodes resolved, and he cleared a PG entrance exam. He's actually completed, by this time I think he would have completed his MD medicine also. But I just shared this experience to say the fact that lots of time doctors are aware of this condition, but what I am saying is somebody was suffering from it, and well, he never got himself evaluated. So lots of time we doctors tend to neglect our health. That's one point I wanted to say, and this is again an important topic, guys. I mean, examiners love to ask regarding delta waves, and sometimes they might change the question also by changing the language of the question. Now just look at the minor point that I'm gonna say. It will look minor at the moment, but in the exam might be, changing the entire domain. He might say delta wave in EEG of the patient. Now that's gonna change the entire domain, no, because I was talking about delta wave per se with respect to ECG, whereas delta wave in EEG is found in NREM stage 3. If you go through the EEG and the epilepsy lecture, I have definitely talked about it. So I said, okay, it's a minor aspect at the moment for you, but do read the question, because sometimes people tend to mess up on this. Delta wave in EEG is NREM stage 3. Let's look at one more such minor finding which is to be remembered. The question asked in one of the NEET exams was pseudo P pulmonale is found in. Now, a lot of guys casually read and thought it is P pulmonale, pseudo P pulmonale. If you go through the electrolyte imbalance part, if you go through the ECG and hyperkalemia with hypokalemia changes, then I have highlighted this statement of mine. Pseudo P pulmonale as a feature of hypokalemia basically means that the P wave vertical height will be more than 2.5 millimeter. In the absence of pulmonary artery hypertension, I repeat my statement once again, guys. The meaning of this word would be that there is no pulmonary artery hypertension and still the vertical height is increased. That is why that word pseudo is used. So these are two accessory issues that I wanted to remember. And the objective of the current part of the discussion was to sensitize you to conditions which would be having a short PR interval. At the moment, we have discussed two of them. Both require radio frequency ablation, WPW and LGL. The next component of the ECG that I'm going to explain to you would be aspects related to the prolonged PR interval. And here we shall be talking about the various types of heart blocks, that is first degree, second degree, third degree. So I will be drawing a couple of line diagrams here where I'll try to explain how you can easily differentiate in a limited time frame between these various varieties of heart blocks. The problem is that the person will be having effort intolerance, and there could be pre-syncopal attacks, there could be even syncope developing in the patient. Whenever you're going to read this word first degree heart block, then the problem in the patient is not inside the SA node. The problem is neither inside the AV node and neither in the bundle of hairs. The problem is in between the connection. Like in this case, what I'm showing in the form of these red dots can be taken as a representation of Ashkoff nodules or non-case-setting granulomas or sarcoidosis. So they will slow down the conduction. See, AV node is anyway slowly conducting. As I've highlighted, there is always a AV nodal delay of 0.1 second when the current goes across the two sides of the AV node and then hits the bundle of his, and then it will utilize the Purkinje circuit and will cause ventricular depolarization. I have just put some pointers here to say that the exact damage in first degree heart block is between point number A and point number B, that is the connection between the SA node and the AV node per se. When it comes to the firing of the bundle of phase, when it comes to the septal activation, it's perfectly fine. Now we will understand why is it happening. The usual cause for it, or rather a common cause for it, this happens to be physiological. But because physiological is something that is unlikely to be asked in the exam, so I'll talk about first the traditional ones. As I highlighted, you could be having rheumatic heart disease. In fact, if you listen to the discussion of rheumatic fever, in the minor criteria, I have specifically pointed out the word prolonged PR interval. Why? Because when the conduction speed will become slower, there would be a bradycardia, and therefore, as I explained, heart rate and PR have an inverse relation. The next example is sarcoidosis. Even in the topic of sarcoidosis, I've highlighted this fact, and cardiovascular mortality is anyway a big problem in all patients having rheumatological disorders. Then can be iron deposition. The disease that I'm mentioning at the moment is hemochromatosis. It can be either of the primary and the secondary variety. This will cause a stiff heart. So the problem in hemochromatosis is, one, it can cause a cardiomyopathy. Second, it can hamper the conduction system in the heart. The next disease is more common in the southern part of India, and look at the longish name that I'm going to write before you. The disease is referred as endomyocardial fibroelastosis. When you just focus on the word, you see fibroelastosis is telling you that there is going to be fibrosis in the deeper layers of the heart. Mainly the conduction system is going to be hampered. As a result of it, the conduction speed can be affected. Now, if they ask you what is overall the number one cause of it, then as I highlighted, it would be answered as physiological. It will mainly be athletes. I can give an example of this athlete being a high performance athlete. Rather, he's a marathon runner. You see, marathon runner is gonna complete 42 kilometers in limited number of hours. That requires a substantial amount of stamina. So the heart always gets into oxygen conservation mode. People who are marathon runners or do these endurance sports per se, they tend to have a high vagal tone, and this high vagal tone explains the first degree heart block to be physiologically present. In those circumstances, obviously nothing is to be done, but let us now actually look at how the ECG of this can be given to you. Let us assume while you are sitting comfortably and you are listening to me with your headphones on, you are listening to this lecture. Because you're sitting comfortably, let us assume that your PR interval at the moment is 120 milliseconds. I've already given you the range. 120 to 200 milliseconds is the range for any one of us. That's going to be about 3 to 5 small squares. Now, if I request you to, just get up and from your chair and do a couple of sit-ups. You see, all of your young people, you can definitely do 4, 5, 6 sit-ups. I just requested you to do only 5. Now, when you will do sit-ups, then the point is your heart will have to work more, so your heart rate will increase. And when your heart rate will increase, then the PR interval will become relatively lesser. So my point is that our PR interval is not constant. It tends to change with the heart rate. I've already explained this concept earlier by simply saying heart rate is inversely related to PR interval. Here I just said that any kind of physical activity that you do, like sit-ups, push-ups, planks, whatever, the PR interval will become relatively lesser. So in you and me, the PR interval will vary with exercise. But in patients of first degree heart block, this variation will not be there. The PR interval will always remain prolonged. It can be even more than the normal limit of 200 milliseconds. Like what I'm saying is that in a normal person, the PR interval will change with physical activity. If there's going to be vagal stimulation, the PR interval will become prolonged. If there's going to be sympathomimetic stimulation, PR interval will become shorter. PR interval in normal person is always variable. This variability will be lost because of the reasons that I explained to you in the previous slide, ranging from granulomas to iron deposition to fibrosis developing in a heart. So people with first degree heart block will mainly come to you with the complaints that I cannot run as fast as I used to do earlier, or he might compare himself with his wife or with his children or anybody else, especially if the person would like to do any kind of minimal physical activity, not only about running row. It could be something like just climbing a flight of stairs. So exercise intolerance and fatigue is the usual reason, and these are relatively initially very non-specific complaints. So you might even miss the diagnosis, but subsequently, because the complaints are persistent, you decided to get a ECG done. In this person, you will always notice that the PR interval will always be in excess of normal. It will always be more than 200 milliseconds and will not change with exercise. That's the point. It will not vary with exercise like it can happen in you and me. Now the point is, if pacemaker will malfunction, we can change it. But obviously, suppose the correction is hampered, then you can't do much for these patients. So there's definitely no treatment. The word is no treatment for first degree heart block patients. Yeah, in some books, I'm just mentioning it offhand. In some books, it might be mentioned that oral atropine can be used in these patients. That's just an offhand remark because atropine can slightly increase the conduction, reduce the symptoms, but then there's side effects also. No? If you give atropine or oral on a regular basis, it will cause a lot of side effects also. So we have to obviously balance between the benefit versus the loss fact. In this condition, all I can say to the patient is that you should not do any strenuous activity, weight bearing activity, or trying to climb stairs with a backpack on your back. Maybe you can climb stairs slowly. But don't try to put too much of stress, because if he ends up with syncope, he can end up with a hand injury as well. So as such, first degree heart block will not cause an immediate threat of life. Yes, the patient will require some modification in his lifestyle. It is that, he's not supposed to carry a heavy weight. He's not supposed to carry heavy grocery bags. He's not supposed to carry a backpack of 10-20 kg on his back. Like normally when we are like shifting an apartment, we people are like buying grocery from the grocery store, we might be carrying heavy bags. This guy will definitely have some issues with that. So just I would say that restriction of strenuous physical activity is what is recommended for these patients with first degree heart block. And now we will be comparing this with second degree heart block, which is the one that is usually asked in the exam. There are two variants of it. One is gonna be Mobitz 1 heart block. The second one is Mobitz 2 heart block. So I'll hand draw the ECG before you to actually explain how the manifestations in these patients will develop. Please remember that lots of time in the multiple choice question, instead of writing the word the traditional Mobitz one, they would love to ask this, I would say longish name, that is the technical name, that is Wenckebach phenomenon as well. And let's now understand how this Wenckebach phenomenon will evolve in the patient. I mean, where is the problem? So I have once again highlighted the SA node. It is gonna conduct into the AV node. The both sides of the AV node, the fast flow pathway will ultimately cause septal activation. Bundle of phase is gonna get activated. In these patients, the problem is not in the SA node. The problem is not in the conduction pathway up to the AV node. Yeah, there is definitely a problem because AV node is conducting even slower than what it normally does. But at the same time, the way I've drawn the diagram before you, I wanted to highlight that the exact site of lesion in these patients is between point number B to C, and that is inside the AV node. So lots of time they might use the word intranodal to describe Mobitz 1 heart block. Now let us understand how the ECG of this person will evolve. When you will scan the ECG from left to right, you will notice a progressive increase in the PR interval of this patient. Please be patient while I just hand draw the same before you, because the easiest for me is to show you a ECG, but then the point is lots of time you might miss up a couple of facts. So let's just try to hand draw this so that we can get a better orientation. You see, whenever you will see the ECG of this person, you will always see an area where actually after the P wave, you will be noticing there is no QRS complex. You definitely can differentiate between the T wave and the P wave based on the height criteria. I've explained to you that the height of the T wave with the limb lead is 5 millimeter. In P wave, it is 2.5 millimeters. So by the height, you can differentiate. But now I'm just putting a vertical arrow here to say that this is the site where I expected the QRS complex to be present, but it is sadly not present. This is the time the patient might actually put his own hand on his pulse, and the patient might say, sir, my pulse just disappeared. I mean, this person, he is putting his own fingers on his pulse and showing you, sir, see, my pulse just disappeared, and I felt as if my head was going round and round in circles, and I felt I might become unconscious, because this is the time when the ventricles did not fire. If the ventricles are not gonna fire, then the cardiac output will definitely be hampered in the patient at that particular point of time, and then the rhythm will be reset. You will notice once again the PR interval of the patient will definitely be present in the next beat. Serially, again, the same pattern will evolve. Again, the PR interval of the patient will start progressively increasing. So if I just put pointers here, I wanted to say that suppose the PR interval initially was 160. Then it jumped up to, let me say, 190 milliseconds. Then it jumped up dramatically to, let me say, 200, or let me say 210 milliseconds. I'm just putting in some random values here to say that there is a progressive increase in the PR interval. And let's zoom it in for your convenience. You definitely can notice that the number of squares between the P wave and the starting of the Q wave. Remember, PR interval is not up to the R wave, it is the starting of the Q wave. The PR interval is definitely showing an increment. And then this pattern is again getting replicated. You again can see 160, it will again become 190, and the subsequent one I can also draw before you, saying that now it would be 210 milliseconds, and this is gonna go on and on. Now in the exam, your query would be that, sir, if I count so many times, there's a distinct possibility that I might forget. Like suppose I'll put it on myself. Suppose in the exam, in a stressful situation, I'm counting the PR interval the first time, the second time, and the third time. There's a possibility that when I'm counting the PR interval a third time, I might forget what was the value the first time. So what he says is that the moment you identify the missed beat, listen to this part carefully. He says, moment you identify the missed beat, which will usually be given in the exam in the form of a vertical black arrow, this highlights the fact that at this point of time, QRS complex should have been present, but is sadly missing in this case. All you need to do then is, listen to the words carefully, All you need to do, if you identify the missed beat either by the vertical arrow given by the examiner, suppose it does not even give it, you can at least identify the P wave now. And after the P wave, there's no QRS complex. You just need to look at the PR interval after and then before, and you will notice the fact that the PR interval after and before will always be unequal in Mobitz 1 HUD block. I want to repeat this again, guys. If you want to get this question right in under 1 minute time frame, all you need to do is look at the PR interval after and before, and you would definitely be more confident in evaluating Mobitz 1 HUD block. In fact, when I'm going to describe or hand draw the ECG of Mobitz 2, you will find this will become even more easier. Now, please remember that you can definitely count the conventional way of counting the PR interval the first time, second time, third time, fourth time onwards, but there's a possibility that it might skip out of the mind. So to minimize the errors, he says count the PR interval only 2 times. And when I describe this for Mobitz 2 HUD block, you will notice that the things will become relatively even more easier. So when it comes to Mobitz 2, let me first try to explain where is going to be the lesion present. So once again, we're going to just put some pointers here. This is SA node, AV node, then the bundle of phasor. The pointers are highlighting the conduction from the SA node to the AV node, inside the AV node, and then there is a septal activation with respect to the bundle of phase. Now, what I want you to understand is that in people with Mobitz 2 HUD block, the problem is below the AV node. Mark my words there, the problem is below the AV node. It is actually the lesion is in the bundle of phase. Therefore, the technical term that might be used lots of time to describe Mobitz 2 HUD block is infranodal HUD block. In fact, earlier, though I had said it, I had not written it. When it comes to Mobitz 1 HUD block, because it is inside the AV node, I repeat the fact, it's inside the AV node, so he will say the word intranodal. You see, again, he's trying to play around with English words there. It is intranodal versus infranodal because obviously it's inferiorly located. Now, the point is PR interval is the distance between point number A to point number C. Please be clear, PR interval does not mean conduction from SA node to AV node. It is SA node to exit from the AV node. So PR interval is point number A to point number C, and the damage is at point number D in this diagram. So therefore, PR interval is not gonna change. There's gonna be sudden drop beat, yes, but why PR interval is not changing is because damage is not in the area per se which represents the PR interval in the ECG. The damage is below the area which is beyond the PR interval representation. So per se, you are gonna get a ECG which will be having 160, 160, 160, 160, and then a drop beat. In this particular hand-drawn sketch, what I will try to do is, I will try to make it as symmetrical as possible, the PR interval. Like I have tried to make it almost the same duration. This is 160, 160, 160, can be continuing for 4 or 5 beats, perfectly normal till now. I mean, so far so good, no problems. But then you will notice that there is a P wave, and then you waiting. There is no QRS complex, and if he's kind enough for you, then he might actually give you vertical black arrow highlighting the area of the missed beat. And even at this point, the patient might volunteer information that doctor, I started feeling dizzy again. In between, because the bundle of phase is exhibiting a very erratic behavior, sometimes he conducts, but sometimes he's not conducting. So because of this, there would be a sudden drop beat occurring in this patient. And then once again, the rhythm will be reset. You will notice that if you look at the PR interval after the missed beat, it would be 160. And now there is absolutely no problem going on till the pattern reoccurs. It is not necessary that it will occur after 3 beats only. It could be 4, it could be 5, it might be continuously happening like normal sinus rhythm for 3-4 minutes, and then there could be a sudden drop in the conduction in these patients. And therefore, what you need to do in the exam is very simple. All you need to identify is the area of the missed beat, and then look at the PR interval after, then look at the PR interval before. You can very well notice that in Mobitz 2 HUD block, the PR interval before and after is always going to be equal. So guys, the main message from this slide is, and I would be really happy if you can just hand draw this diagrammatic representation by yourself at least once, so that you get a hang of the stuff. When it comes to Mobitz 1, it is going to be a scenario of prolongation of PR interval, drop beats, then it's going to be again a prolongation. So all you need to do is calculate the PR interval 2 times, before and after, or after or before, that does not matter. Point is, in Mobitz 1 it's gonna be unequal PR interval, in Mobitz 2 it's always gonna be equal PR interval. That is how you can easily identify. And I want to also highlight the fact, and I'll prove it to you subsequently, that Mobitz 2 is more dangerous than Mobitz 1. Why? Because Mobitz 2 occurs very suddenly, whereas Mobitz 1 occurs gradually, so the heart gets used to it. But in Mobitz 2, which is going to be suddenly developing manifestation, in fact, they can even be sudden death. I'll even prove it better on my subsequent slide where you'll get more leverage of more space so that I can explain this to you. But at the moment, I want you to remember, I have taught you already sudden death in MI is due to ventricular fibrillation. But if he says which bradyarrhythmia causes sudden death in MI, the answer is the topic that I've just explained to you, Mobit's word block. I'm going to repeat this again, guys. Tachyarrhythmia in myocardial infarction that occurs as early as the infarction has occurred within the first few hours only, preferably might occur in the very first hour only, and the person might die also. That's going to be a scenario of ventricular fibrillation, tachyarrhythmia. But when he talks about specifically bradyarrhythmia, your answer should be given as Mobit's 2 heart block. That is also called as infranodal heart block. And this entire slide, I would rate that as the most important slide from the bradyarrhythmias component, because most of the people, they tend to get tired counting the PR intervals. So I've just given you a hack which will definitely work almost every time. That is, just look at the PR interval 2 times before and after, and you will have a fair amount of idea. In fact, practice this in the subsequent questions given and you will feel more confident about it. Now I shall be explaining to you regarding third degree heart block in a patient. So let us first study that where is going to be the lesion present in this person, and then compare the ECG of this person with respect to the second degree and first degree heart block. The main problem in third degree heart block will be problem of the AV node. Now, I want you to listen to this part very carefully, because when I start talking about damage to the AV node and no conduction by the AV node, the usual query that I get from most of the students is that, sir, you taught that the damage in the AV node is also present in Mobit's 1 heart block. Remember, in Mobit's 1 heart block, I had said the word intranodal. I'll just go back to my previous slide. You see, you can also see that in Mobit's 1, the damage has been shown precisely in this area, that is the AV node per se. So what is the difference? I want to highlight that when it comes to person suffering from Mobit's 1 heart block, it is relatively a slow conduction. Please listen to this part very carefully, otherwise we miss out on the main gist of the discussion. When it comes to Mobit's 1 heart block, it's always gonna rather be because of the slow conduction. But when it comes to the current diagram, I have used the word no conduction. So that fundamental difference should be remembered. And the importance of knowing this information now is that SA node will not be able to control the ventricles. SA node will definitely be able to control the atria per se, and the firing of the atria will occur. The atrial rate will be approximately 100 beats per minute. No issues with that. But yours and mine, per se, the ventricles are controlled by SA node. But in this case, who's going to control the ventricles? Bundle of his. You see, whenever a pacemaker is malfunctioning, the pacemaker below it will take over the function. So in a person of third degree heart block, it is rather ventricular rate being controlled by the bundle of phase, as a result of which the ventricular rate will be only 40 per minute. Now, if you look at the mathematical association here, atria are beating about 2.5 times faster as compared to the ventricular rate. So one reason why these patients will be having syncopal episodes is AV dissociation. I have talked about AV dissociation with respect to tachyarrhythmias also. That is going to be ventricular tachycardia. You will read about this in the subsequent part of the discussion, that is ECG and arrhythmias part 2. But I want you to remember that AV dissociation as a word is read 2 times primarily by you. One in the topic of bradyarrhythmias right now, and second will come in the tachyarrhythmias component subsequently. Bradyarrhythmias is third degree heart block and tachyarrhythmias is ventricular tachycardia. The meaning of the word AV dissociation would simply mean that there is lack of coordination. You see, I have explained that atria contribute 30% of filling of the ventricles. If there's going to be lack of coordination, then the filling of the ventricles will definitely be hampered. And if input is lesser, output will obviously be lesser. Adding insult to the injury will be bradycardia. You see, there are two reasons why the cardiac output in third degree heart block is low. One of the reasons for low cardiac output is AV dissociation, and the second component is obviously what is written here, but still I need to put it for record purposes, bradycardia. I mean, heart rate of 40. You see, while you're sitting comfortably on your couch and listening to me with your headphones on, your heart rate, even when you're sitting comfortably, will definitely be more than 60. It would be something in the range of about 60 to 100. In this guy, the maximum heart rate possible is only 40 per minute. So most of these patients, especially when they change their position from supine to standing, or let me say this person went to the washroom. It could be an Indian kind of a toilet or a Western kind of a toilet. When the person suddenly stood up, there was a syncopal episode developing in this person. So most of these patients will be having postural hypotension developing. Now obviously patient does not know about postural hypotension component. So for the patient per se, he will just, or the family members will tell you that there have been not one but multiple such syncopal attacks in this person. The message is, Recurrent syncopal attacks can occur in diabetic neuropathy patients as well, but today we're talking about a bradyarrhythmia, which is directly decreasing the heart rate, contributing to lack of coordination between the upper chambers, that is the atria and the ventricles. And as I highlighted, atria contribute 30% of filling of the blood of the ventricles. So 30% BP value is anyway lost since the atrial contribution is not there. This is also going to contribute to development of super large A wave. That super large A wave would be called as Canon A wave. Canon A wave is different from large A wave. I can call Canon as super large A wave as well. Now we will focus on the ECG component of this person. I'll also mention a pediatric important cause for this condition too. You see, the main agenda that you need to understand with respect to this condition is that the number of P waves and the number of QRS complexes, they always match in you and me. I mean, you check out any ECG strip of a normal person. If there's gonna be a P wave, then there's gonna be a QRS complex, that is normal sinus rhythm. So number of P waves will always be equal to the number of the R waves per se or the QRS complexes. In this person, the ECG tracing will come like this. You will get a P, then maybe again a P. You expected after a P a QRS complex? No, it's gonna be again a P. Why? Because atria are firing at a faster rate as compared to the ventricular rate, and then you are waiting for the ventricular contraction to occur. So there might be a prolonged PR interval followed by a relatively broad QRS complex. Now, why it is a broad QRS complex in this case is because the control is via the bundle of His. The control is not via the SA node. So the conduction speed of bundle of His will be relatively slower. You can then notice a T wave coming up, then after P again another P coming up. Then I'm waiting for the QRS complex, which is relatively broader. I'm sketching a T wave at the moment, again after P another P wave. Now if you look at the number of the P waves or number of times I've just said the word P, it is much more in number as compared to the R waves present in the ECG of the patient. So one thing that is very striking in this particular ECG is the disparity between the number of P's and number of R waves or the QRS complexes. The duration of the QRS complexes is also brought. Another interesting feature which I can highlight is that when it comes to calculating the ventricular rate, and for this look at the red markings first. You see, if I have to calculate the ventricular rate of a normal person, I will be calculating the distance between the R and the R wave. So ventricular rate is determined by RR interval. Now suppose I have to determine the atrial rate. I mean, in a normal person, how do I know at what rate the atria are firing? Then the distance that I will be taking will be the distance between the P wave and the subsequent P wave. I want to highlight it once again. It is the PP interval in you and me that decides the atrial rate, and it is the RR interval that will decide the ventricular rate. But in the person whom I have shown inferably, you will notice a huge disparity. I mean, just look at the RR interval. It is huge, and then compare this with the PP interval. The PP interval is much lesser. So one of the very striking ECG findings that will always be visible in a person who's having a complete heart block is that the PP interval will never match. In you and me, PP interval and RR interval is always equal. But in this case, I'm just putting a sign here just to say no matching between the PP and the RR interval. And mathematical reason for that has already been provided to you. Atrial rate is going to be 100. That is 2.5 times faster than bundle of phase. Mathematics, bundle of phase fires at a maximum rate of only 40. The QRS complex in this case will be relatively broad. It can be towards the upper side of normal as well in some ECGs. And as I highlighted, an important feature, number of P waves is not going to match with the exact number of the R waves also. So when you read or you encounter such parameters, it can be both a theory based as well as a practical ECG based question. You will definitely be able to decipher this condition of third degree heart block, because it can definitely cause head injury in a person due to recurrent syncopal episodes. We need to treat it. Well, what is the treatment for third degree heart block? I'll tell the patient that I would like to suggest you for a permanent pacemaker. And I will also talk about what is the site of putting the pacemaker, how the electrodes will control the heart. But at the moment, I want you to remember that first degree heart block, we do not use pacing. In Mobitz 1 heart block, again, there is usually no need for any kind of pacing because it's a gradual increase. So therefore, the increased PR interval causes a bradycardia, but the patient and the heart usually becomes used to it. It is only in Mobitz 2 heart block treatment is required, which will be discussed subsequently. And in third degree heart block, it is permanent pacemaker, which is required. The message here is that in this permanent pacemaker, there will be two wires. One wire will be controlling the atria, the other wire will be controlling the ventricles. Because see, in this guy, the problem is there are two pacemakers in the heart. As they say, too many cooks spoil the broth. One pacemaker is controlling the atria, other one is controlling the ventricles. I want to suppress both of them. Now it is the computer that will be controlling. I repeat the fact once again. Too many cooks spoil the broth. As they say, too many people are spoiling a dish which could have been, a very tasty one. Now what I'm saying is I'm going to suppress both of these guys. I'm going to say, please, both of you shut up. And now it's going to be a computer that will be put in the chest of the patient that's going to suppress both of them, and rather there would be two wires going from the computer to suppress them, and it is the computer that will control the simultaneous contraction of the ventricles, as well as a sequential contraction of atria and ventricles. First atria have to contract to fill blood into ventricles, then ventricles have to contract. Now both do not have to contract at the same time. So lots of time in MCQs, instead of writing the word permanent pacemaker, which is obviously easy, and in fact I can say even a non-medico can understand, that if there's a severe bradycardia, then pacemaker is put. For you guys as doctors, the technical input he might ask is dual pacing is recommended for, then your answer would be given as the topic that we're discussing, third degree heart block. At this particular point of time, I just want to make you revise that there are four pacemakers in the heart: SA node, AV node, bundle of His, and Purkinje. And whichever pacemaker will malfunction, the pacemaker below it will take over the functioning. SA node can fire at a max rate of about 60 to 100. And the disease that can develop here is called as sick sinus syndrome. Now, suppose there's a sick sinus syndrome occurring in any person, then what is going to be the problem? The problem is going to be that now the heart rate of the patient will be maximum only 45 to 60 beats per minute. I'll just put in the physiology values once again. SA node fires at a max rate of 60 to 100. If it will malfunction, then AV node will take over. Max firing rate is 60. If the top two will malfunction, then it is bundle of His which can fire at a max rate of 40 or lesser. And suppose, God forbid, if the superior three are malfunctioning and it's only going to be the Purkinje taking over the heart, then the heart rate is going to be only between 15 to 20 beats per minute. That is just too less, guys. This can definitely contribute to sudden death in a person. Now, in a person who's suffering from sick sinus syndrome, the ECG will evolve like this. There will be no P waves because SA node is very much not functioning at the moment. So you will be getting a QRS complex that might be normal, slightly delayed or broad. Then there would be a T wave. You see, I am describing a ECG in which there is going to be absent P waves. There is a tachyarrhythmia in which there is absent P waves, that is atrial fibrillation. But at the moment we're talking about a bradyarrhythmia in which there is absent P waves, which is going to be sick sinus syndrome. T waves might be decipherable, but before every QRS complex, what should always come is a P wave, which is missing in this case. So I'll just put a pointer here to highlight that I expected a P wave to be present at any of these areas, but it is missing. In fact, at this juncture, what are the scenarios in ECG where P waves are going to be absent? One is electrolyte imbalance. If hyperkalemia occurs of the severe variety, then the P waves tend to disappear. Then it is absent in atrial fibrillation, and it is also absent in the current condition we are discussing, that is sick sinus syndrome. So you can just remember this information as well. In fact, whenever I talk about specific ECG findings, it's always a good idea to correlate it with whatever we have talked about earlier or will be coming subsequently. Like there might be possibility I might be discussing some topic in sequence later, but you can definitely come back to it. Like this statement is again important exam wise: conditions having absent P wave. Now we will focus on what's going to happen in a person if it is the AV node that is malfunctioning. Then the disease of AV node malfunction is going to be answered by you not as Mobitz one heart block, because in Mobitz one heart block at least some conduction was occurring. It was relatively a slow conduction, but now I am highlighting no conduction occurs in complete heart block. The condition has AV dissociation. In fact, lots of time you might even read an alternative terminology for it, that is Stokes-Adams syndrome. And in fact, I want to at this junction also highlight that in patients, especially women with SLE, there is an antibody called as Rho antibody. This Rho antibody in a lady with SLE can actually be transmitted from the placenta to the baby and can damage the conduction system, that is destroy the AV node, and therefore complete heart block can also be a presentation in pediatrics of what is called as neonatal lupus. I repeat the fact once again, guys. Rho antibody in SLE is the one that is responsible for photosensitivity. Like you're aware of, obviously, antinuclear antibody, double-stranded DNA, and other antibodies, which are very routine ones, right? I'm saying Rho antibody causes photosensitivity in SLE and can even be transmitted across the placenta, contributing to neonatal lupus. And when it comes to a person with a complete heart block, the ECG will be appearing in this fashion. There would be a P, then again a P. You waiting, you will get a QRS complex, not a missed beat, but a broad QRS complex. And then you can very well notice the number of P waves in the sketch are much more as compared to the R waves or the QRS complexes, which obviously should not occur. Now I'm going to create a worst case scenario for you where there is going to be damage to the bundle of his. Now, the disease or damage of bundle of his is not called as bundle branch block. That's the main reason I'm discussing this again, guys. Disease of bundle of his is not called as bundle branch block. Bundle branch block is damage to the left fascicle, right fascicle. That is discussed subsequently in the app inferiorly. If you scroll down, at the moment I want to tell you, disease of the bundle of his is Mobitz to heart block. And now look at this. In Mobitz to heart block, you will very characteristically notice heart rate will be how much? Only 15 to 20, and 15 to 20 is compatible with life? Definitely not. That is why this is the most dangerous one, because usually in a face-to-face or a live class, when I ask my students which is the most dangerous heart block, most guys casually say, sir, complete heart block. No guys, in complete heart block the heart rate will be how much? About 40. But when it comes to a Mobitz to heart block, because now it is going to be Purkinje that will be controlling the heart rate. Heart rate is only going to be 15 to 20. That is not compatible with life. That is what is going to contribute to unfortunate mortality of the patient. In Mobitz to heart block, let us now redraw the ECG, how it's going to evolve. You will be noticing a normal PR interval. At the moment, everything is perfect. I mean, that's the usual query of most students, sir. If everything is normal with respect to PR interval, then what is the problem? The problem is that there's gonna be a huge period where there was no ventricular activity, and if you do not have any ventricular activity for a substantially long duration, then obviously the person will develop syncope. In this particular representation, I've also tried to highlight that the PR interval after and the PR interval before will always be equal. So wherever you notice the misbeat, as I explained, just calculate the PR interval before and after, and you would be able to understand the concept relatively better. For just completion of this topic, I am gonna mention the heart rates here. In 6 sinus syndrome, the maximum heart rate possible for a person will be 45 to 60. In a person with complete heart block, the heart rate can be maximum about 40 per minute. But in patients of Mobitz to heart block, here the heart rate will suddenly dip. In this gap, you see, there would be substantial gap, and the heart rate will decrease to only 15 to 20 beats per minute, which is going to be excessively low. And because of this exceptionally low values, well, the bad news is there would be hypotension and then possible death in the person. I've already explained that in Mobitz to heart block, there can be sudden cardiac death. An alternative name for complete heart block can also be third degree heart block. So in fact, for third degree heart block, I have set two alternative names: complete heart block, Stokes-Adams syndrome, and the pediatric version that is called as neonatal lupus. You also have to remember that in Mobitz to heart block, because the heart rate is dramatically reducing at the moment, it may not be feasible to put in a permanent pacemaker in the person because he's not fit enough for it. So if he asks you, when do you do a temporary pacing, or when is a temporary pacemaker put in a person, then your primary answer would be given as the topic that I just explained, Mobitz to heart block. In fact, subsequently, when you will read the lecture of symptomatic bradycardia with pulse, which is given inferiorly in the app, you will see me using an alternative terminology, that is TCP, that stands for transcutaneous pacing, and TVP, that is transvenous pacing. The details of transcutaneous pacing and transvenous pacing are present in a subsequent lecture. At the moment, I just want you to remember this casual word, because if I go into TCP, TVP, it will change the entire domain of the discussion. So I want you to mainly focus on the word temporary pacing. If he changes the question and says, what is first line management for a person with symptomatic bradycardia, then at the moment, suddenly if the heart rate is dropping, first I don't know what is the reason behind it. So I will obviously give atropine, and the dose of atropine has changed. Earlier it was 0.5 milligrams, but the current dose of atropine that we give to the patient is 1 milligram. So do remember this slight change as well. I repeat the fact once again, maximum dose of atropine is still the same. How much is the max dose of atropine given in resuscitation bradycardia? 3 milligram. So it can be 1 milligram milligram, three different shots at varying intervals of 3 to 5 minutes. But the message is we are having a change from 0.5. It is upgraded in the current American Heart Association guidelines to 1 milligram. TCP is transcutaneous spacing. TVP would stand for transvenous spacing. And these are some technical aspects that I definitely want you to remember, so that in comparison, if they give you a ECG, you should be able to pick up the various varieties of heart blocks. Now, moving ahead in our discussion, I will be teaching you regarding where do you put in the pacemaker and how this pacemaker circuit will be functioning. In fact, now these pacemakers are not going to be affected by any kind of radiation. I can put it like this: when I was a student at your age, the pacemakers that were put, they had a peculiar problem that when a person used to go to the airport, he had to actually declare he is having a pacemaker, and therefore these patients were exempted from screening. That metal detector that they use at the airport, that could actually interfere with the functioning of the pacemaker. So these patients were exempted from any kind of magnet based devices which can actually interfere with the functioning of the pacemaker. But now obviously, I mean, things have become much more advanced. We will have a person with a pacemaker going through a airport security without a hassle. He can go to a mall. Even at every mall there might be metal detectors or scanners present, or for that matter he can keep his cell phone in his left breast pocket, because you see, cell phone also has a radiation, cell phone also has a electromagnetic waves radiating from it. Earlier, I mean, people were told to keep away from electronic devices, but with current generation of pacemakers, there is absolutely no problems. Well, what is the site where the pacemaker will be implanted? So it would be the left side of the chest, obviously. And where would it be put? So left side of the chest, infraclavicularly, just below the skin of the chest. I repeat the fact once again: the site for pacemaker is left side of the chest. IC here means infraclavicularly, and the batteries and the hardware both will be deployed. The batteries and hardware are just below the skin of the chest, but when it comes to the wires or the leads per se, the leads are going to go through the soft tissues and touch the heart. Now we are going to study that these leads of the pacemaker are going to go and touch which surface of the heart, because there are four chambers: right atria, right ventricle, left atria, left ventricle. So you guys tell me logically that the pacing lead per se should go and touch which surface of the heart. The first thought process that I usually find being answered by most students in a face-to-face class is that the pacing lead should touch the right atria. Well, a correct thought process, but the problem is that after the SA node, there's a AV node, there's a bundle of phase, and tomorrow if they malfunction, all the hard work will go loose or waste. So at the moment, the guidelines were that the pacing lead or leads, if we talk about the oldest generation of pacemaker, I'll put it as a single lead pacemaker. Single lead pacemaker was first deployed in America in 1950, and they did not make that wire of the single lead pacemaker touch the right atria. Yes, guys, in a single lead pacemaker introduced way back, large number of years back, the wire was actually touching the right ventricle. Why? Because if you control the right ventricle, you can control blood going to lungs. Because one of the important functions of the heart anyway is to control the blood going towards the lungs per se. So the objective was only to ensure at least the heart is able to do its one function, sending blood to lungs. The lungs will obviously oxygenate the blood. Once it comes to the left hand side, it will flow into systemic circulation. But with technology coming in, obviously we have a dual lead pacemaker. We also have a triple lead pacemaker. The latest generation of pacemakers which are available at the moment are triple lead pacemakers. Here there will be multiple wires. One wire will control the right atria, another wire will control the right ventricle, because we need to obviously send blood to the lungs. The third wire is going to control the left ventricle. On this, the query of most doctors is, well, why are you not trying to control the left atria? One, I want to say that if oxygenated blood will come in the left atria will automatically be able to do its job. And second, the more control I try to achieve, I will obviously consume more battery. It will require more sophisticated circuit as well. In a nutshell, the technology has been apt to ensure a proper firing of all these chambers at the right time. We are able to ensure proper blood to go to lungs for oxygenation, and once we time the left ventricular contraction or ejection, systemic circuit and cardiac output will definitely be obtained. Dual pacing will control the right atria and the right ventricle, and I've already explained to you that dual pacing will be used where there were two pacemakers malfunctioning and messing up with the situation. That was third degree heart block, also called as complete heart block. Now, when it comes to implantable cardioverter defibrillator, that is ICD, then ICD is a step above all of this, no? Because please remember, implantable cardioverter defibrillator is useful for patients of tachyarrhythmias. In fact, that's the concept I want you to understand. Pacemakers are put where? Whenever person is having bradyarrhythmia, and implantable cardioverter defibrillator is always put whenever a person is having a tendency for tachyarrhythmias. I'll make a list of those conditions where tachyarrhythmias can develop in a person on a recurrent basis. But first, I want to teach you that ICD as a device will do what? It will read ECG better than any of us, because this is a sophisticated computerized algorithm. It will analyze ECG. It can do a abnormal rhythm detection. So you can see it's a smart computer. It can do a job of a doctor much better sitting very close to the heart of the patient. And once there will be abnormal rhythm detection, this computer, small computer, maybe 1 inch by 1 inch in size, sitting in the chest of the patient, just below the skin of the chest, has sufficient power to deliver a DC shock and terminate the arrhythmia without patient even coming to be aware of it that he had some problem. I mean, this is like, nipping the problem in the bud. The arrhythmia occurred, the computer fired a DC shock, and well, goodbye to the arrhythmia. Please remember, implantable cardioverter defibrillators are useful for those patients who are having tendency for tachyarrhythmias, whereas pacemaker is obviously for bradyarrhythmias. Let us now quickly work out the indications for an implantable cardioverter defibrillator. The mnemonic that I would like you to remember is ABC. Alphabet A can be used to remember a structural damage to the heart that can occur post myocardial infarction, LV aneurysm. These patients will have tendency for recurrent episodes of ventricular tachycardia, so it's a good way to control them by putting a ICD. Next is a condition which is self-explanatory by itself. The name is ARVD, arrhythmogenic right ventricular dysplasia. The name itself will help you crack the question because it is saying arrhythmogenic right ventricular dysplasia. It is a subtype of cardiomyopathy where there is a fibrofatty deposition in the right ventricle. Now, fat in the heart and fibrosis in the heart is not welcome because we need myocytes in the heart. If you're going to be having a fibrofatty deposition, especially in the right ventricle, then there could be a voltage gradient created in the heart that could result in development of sudden cardiac death in these patients. Why? Because again, they can develop VT or torsides de pointes. In fact, if you will be doing ECG of person of arrhythmogenic right ventricular dysplasia, you might be able to pick up abnormality which is very characteristic and is called as epsilon wave. This finding will be present right at where the J point should be present. Right in the starting I mentioned no isoelectric point. So at the exact area I've just shown this peculiar wave present which is called as epsilon wave and helps you in identifying ARVD. This is obviously if the person comes in advance when he was symptomatic, when he was having syncopal episodes, and you did a ECG which was showing this characteristic manifestation. Alphabet B would stand for Brugada syndrome. This is a channelopathy. The name Brugada syndrome will always be or very frequently be asked in the exam because there is a sodium channel defect called as SCN5A. In neurology, I have talked about SCN4A with respect to topics like hypokalemic and hyperkalemic periodic paralysis. But in Brugada, it's going to be SCN5A. And here again, we will be having a very peculiar ECG present of ST elevation. But this ST elevation will be either having any of the two patterns. Either it will be called as this, the first one that are drawn is called as Cove pattern. In fact, I've discussed Brugada separately also. So when you scroll through the app, you will notice Brugada discussed subsequently also. But at the moment, I just want to say that because these patients can be having a ST elevation. So one, I want you to remember this for the variants of ST elevation because type of ST elevation in MI and pericarditis has already been discussed. In MI, it is convex upwards. In pericarditis, it is concave upwards. But cove pattern saddleback is to be remembered for Brugada. So these are the subtypes of ST, and these patients can be definitely having these ECG findings in lead number V1, V2 can have sudden arrhythmias in the form of VT or TDP. Any of the cardiomyopathies, whether it be HCM, dilated cardiomyopathy, restrictive, any cardiomyopathy can have recurrent episodes of tachyarrhythmias contributing sudden cardiac death, and therefore ICD will be recommended. So A is aneurysm / ARVD, B is Brugada, and C is cardiomyopathy of any etiology. I want you to remember that just by looking at the X-ray, we can't say whether it is a pacemaker or whether it is an implantable cardioverter defibrillator. But the point is, lots of time they might just simply give you a question which was actually asked like this. He mentioned that the patient is on implantable cardioverter defibrillator. Now look at the surprising thing that the person is saying. He says, "Doctor, I feel as if electrical shocks are going in my chest." First, I thought that does this guy need a psychiatrist? I mean, what is he talking? He's saying, "Sir, electrical shocks are going on in my chest. I can feel contraction of my chest muscles. It hurts also." So first, initially, I was very surprised by the complaints of this person, but since I know that this person is already having an implantable cardioverter defibrillator, he is himself told, patient on ICD, complaints of electrical shocks in the chest. So I started thinking, what could be going wrong? You see, symbolically speaking, I can draw like this. If this is implantable cardioverter defibrillator, this is the heart, then obviously connecting the two will be wires or leads, and these leads will be causing a two-way transfer of information. I mean, if the heart is beating properly, the electrical activity of the heart will be transmitted to this computer, that is ICD, and the computer is programmed that if this information is not present or the information is abnormal, then the computer knows only one thing to do: deliver a DC shock and get rid of the arrhythmia. Now what I'm saying is, hypothetically, just imagine the leads will get fractured, you see, due to I would say either poor quality, or maybe I can say just accidentally it just happened with this person. Is a unlucky fellow, there was a lead fracture. So you can see that now the stimulus to the ICD, the computer is not receiving any input, so it will start doing what it does best. What will it do? It will deliver DC shocks. But where will they be delivered? They will be delivered to the soft tissues of the chest. And once the electrical shocks are delivered to the soft tissues of the chest, apart from uncomfortable sensation in the chest, there would be chest pain also. The question simply said, what is the first investigation to be done in this case? Then, as you are aware, all the leads, whether it be pacemaker lead, whether it is going to be ICD lead, they're all radio opaque. So first, to determine whether there's a lead fracture or not, or a lead malposition, I can just do a baseline investigation, that is a chest X-ray. The question was a very simple and straightforward one. It just required presence of mind to remember this simple fact that the leads that connect the computer, that is either a pacemaker or ICD, are going to be radio opaque, so you obviously can identify it. Another complication that can occur with ICD and were asked in UPSC exam is that because the wire has to go inside the heart, so it will go via the great veins, because after all, how do you enter into the heart? Via the great veins. So the bad news is the leads which are present in the right side of the heart, or going towards the right side of the heart, they can trigger a superior vena cava thrombosis. It can extend into the right atria, into the right ventricle, and then there could be shower of emboli into the pulmonary circulator. But the point is, implantable cardioverter defibrillator can have two complications that I mentioned. One is lead malposition / lead fracture. That's point number one. Second is because the leads are going via the superior vena cava into the right side of the heart, because lead is a foreign body. So this foreign body can trigger a clot formation, and that is why I said superior vena cava thrombosis can occur. And due to this SVC thrombosis, he might mention about extreme facial congestion. He might mention about extreme facial plethora present in this person. The message here is very clear, guys. It is pacemaker, either of the two varieties, permanent or temporary for bradyarrhythmias. Which bradyarrhythmia will you answer? Temporary pacemaker, move it toward block. When it comes to people who are having sick sinus syndrome, you would be advising a permanent pacemaker. If a person is having complete heart block, again a permanent pacemaker, but that would be dual pacing, because there were two pacemakers controlling atrial and ventricle respectively, as I explained. But in movements 2, because it's a medical emergency, heart rate is only 15 to 20 per minute, I need to deploy a temporary pacemaker. Initially, when I'm not aware what kind of heart block is present, heart rate is, let me say, 30-40 on the monitor, I will straight away be giving atropine to the person. And over and above this, I also want you to remember indications for ICD. In fact, this comparison should be remembered: indications for pacemaker versus indications for implantable cardioverter defibrillator. So these are again two important slides, guys. These are the indications where you put in a pacemaker, and these are the indications where you will be putting a ICD. I would like you to, on a stick-on pad, write both of them, left, right, and just stick on somewhere so that you see them again and again. And once you have internalized this information, like after 1 week, you can replace those stick-on pads on your wall and you can introduce more information. I mean, that's one way, whenever you read lots of information, it's difficult to remember in the first go. Then the best way is just note down the important salient features, stick it on somewhere so that when you see it again and again, it's imprinted into your memory. And as I usually say, I'll repeat that again, doctors are ideally supposed to have photographic memory. So you should try to, get this imprinted into your brain with careful reading and obviously taking notes simultaneously. Or if you have printed ones, okay, no problems with that. But then, my point is that ultimately everything should register. Why is it happening? How is it happening? So that you are able to upgrade your performance. Next, we shall be looking at a couple of ECGs to evaluate these heart blocks once again so that these become a permanent memory for us. In the very first one, when I zoom it in, you will notice that the PR interval of the patient is substantially prolonged. Let's just do a quick counting here. If I count the number of small squares here, they're going up to a huge 6 small squares, which means that the PR interval of the patient will be in the range of about 240 milliseconds. That's pretty substantial. If I do this activity once again, you will notice that the number of small squares is almost going to be the same. I've still highlighted approximately 6 small squares present. So this ECG is highlighting presence of first degree heart block. The main issue with this person would be that either he could be a marathon runner or he could be having any of the pathological reasons we discussed, ranging from rheumatic fever onwards, and the defect in the heart of this person will be between the SA node and the AV node. Please remember the fact that per se first degree heart block would be benign nature and would not contribute to any chances of death. When it comes to the next ECG, you can very well decipher and notice a missed beat present here. How did I pick it up? I noticed a P after a T. You can notice the difference between the T and the P mainly based on the height criteria. And now I'm gonna look at the PR interval subsequent to the missed beat, and I look at the PR interval before the missed beat, and you will notice a huge difference in the magnitude of the PR interval. I have already explained to you that whenever you evaluate unequal PR interval before and after with respect to a missed beat, this would be representative of Wenckebach phenomenon and is called also as Mobitz one heart block, because in this condition there would be a gradual prolongation, so heart will get used to it, and therefore chances of this person having sudden death are significantly minimized. But if you look at the next one, you will notice that there's definitely a P followed by a missed beat, again P wave area, but there's a pretty flat area present here, this particular area I'm pointing at, where there's no cardiac contractility or at least no ventricular contraction that can be visualized. So I am going to look at the PR interval after this missed beat area, and I'm going to look at the PR interval before the missed beat area. You will notice that they are almost equal. I repeat once again, the PR interval before and after looks equal wherever there is an area related to missed beat. So in those circumstances, this would be answered as Mobitz two heart block. The problem with Mobitz two heart block is damage primarily at the bundle of his, and that's a very critical aspect of the heart, because bundle of his is the side which is ultimately going to cause both the left and the right fascicles to ensure that the ventricles are able to fire almost simultaneously. Now, if bundle of his will malfunction, there would be a sudden drop in the heart rate of the patient, and this sudden drop is the one that is lethal. And as I highlight, this can be seen after MI, and person can actually may not be able to reach the hospital also. In the next ECG, you will notice very prolonged, and I would rather say broad QRS complexes. The moment you notice these broad QRS complexes, you need to ask yourself, is this a tachyarrhythmia or a bradyarrhythmia? Because broad QRS complexes are also going to be discussed with respect to ventricular tachycardia, where the heart rate will be going up to the range of about 200. But in this case, if I just count the number of large squares with respect to RNR, and I've already taught you that the number of large squares, that are the only time you're going to read about large squares per se is calculation of the heart rate. I mean, if I look at the mathematical value here, 300 divided by 8, in fact, it's a little more than 8. I'm taking 8 for calculation purposes. So the heart rate of this patient will be something in the range of about 35 per minute, give and take a few values. The point is, if heart rate is this low, it's definitely going to be very, I would say, troublesome for the patient, in a sense that postural hypertension can occur, syncopal episodes can occur, and then I can definitely notice a P wave. I can again notice a P wave. I can again notice a P wave which is present here with a broad QRS complex. And at the same time, I want to highlight that if you count the distance between the R and the R wave, and then if you look at the distance between the P and the P wave, the red is in the movement representing atrial rate, and the green at the moment is representing the ventricular rate, and atrial rate and ventricular rate are not matching. In those circumstances where the atrial rate and the ventricular rate will not be matching, the chances of this person having a fatal event in the form of a head injury are dramatically increased. So the diagnosis in this case would be given as complete heart block. The alternative name for complete heart block is third degree heart block. This has EV dissociation, so can even be having those frog waves present. Frog waves simply means that they would be fluttering in the neck of the person. And the reason for that fluttering I would like to highlight is mainly that when the atria and ventricle will contract together, you see normally first atria contract, then ventricles contract. If both will contract together, then the power of the atria and the ventricles will be added together, and that will contribute to, in fact, super large A waves in these patients. Those super large A waves are technically referred to as Kinon A waves. Now we will focus on a subsequent set of ECG rhythms which are given, and I again want you to appreciate a very particular rhythm that is occurring in this case. In fact, superimpose the tracing so that you can understand this better. You see, at the moment you can notice a P wave. I'll just highlight the P waves first. Obviously, there are multiple P waves present, so I am gonna highlight them. But you will notice that some of the P waves have used a different color to highlight, followed by a QRS complex. Why? Because each of these P waves is being followed by a QRS complex. Let's do this again. P wave is followed by a QRS complex. P wave is followed by a QRS complex. What I am saying, guys, is that we are having a non-conducted. The one that I've shown in color red is the non-conducted P wave, and the one that is shown in green is the conducted P wave. What is happening is alternatively the P waves are getting conducted. So one, I would like to highlight that this that I've shown is actually called as 2:1 heart block. And at this juncture, I also want to say the fact that because after every P, let me just draw a vertical arrow to say that there is no QRS complex. So you might get an impression that okay, this is Mobitz 2 heart block. Because you're getting an impression that this is Mobitz 2 heart block, what will you do? You will look at the PR interval after and look at the PR interval before, but you will notice that because the PR interval before and after is equal, you can answer this as Mobitz 2 heart block. I want to tell you guys, lots of time Mobitz 2 heart block in the exam can be confused with 2:1 block. How do you differentiate that? Well, the way to differentiate that would be that when it comes to 2:1 versus Mobitz 2, in Mobitz 1 versus Mobitz 2, I said Mobitz 1 is easy, PR interval prolongation. Here PR interval is constant, you can see multiple times. So I am saying conducted, mark my words there, conducted wave, conducted wave, conducted wave. Then there is a P wave which is occurring in this case that I marked in red, and this is not conducted inferiorly. That is why there was a missed beat. Again, I'm highlighting that there are a couple of waves which are going to be conducted. So the words are, the English words are in the first image that I'm currently marking 2:1 heart block. The words are conducted, non-conducted, conducted, non-conducted alternatively. The word is alternatively. Whereas inferiorly, you are noticing it is conducted, conducted, conducted. Then there's a drop. Conducted, 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 and then there's a drop. The previous one and the current one, that is the one that I marked at the moment, and the one that I'm marking at the moment, they can actually be a source of error in the exam. You need to use the logic that I have said at the moment. Whenever you are looking at any ECG and answering it as Mobitz 2 heart block, you need to be careful about the fact that is it going to be a rhythm of conducted, non-conducted, conducted, non-conducted, or is it conducted, 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 conducted? It could be 3, it could be 4, it could be 5. If it is multiple conductions followed by a drop, multiple conductions followed by a drop, that is Mobitz 2. If it is conducted P wave, non-conducted P wave alternatively occurring, then it is 2:1 heart block, and that is the main reason I've highlighted this. In fact, with respect to Mobitz 2, I want to say that because Mobitz 2 and 2:1 heart block is confused a lot, so if you can just either take a snapshot of it or hand draw the two rhythms by yourself, again I can highlight that the productivity of yours and the strike rate of yours in questions will increase, because lots of time your rivals might actually casually answer what I just did, Mobitz 2 heart block for the superior ECG. Why? Because PR interval before and after is equal. Yes, I mean, this is a common source of error. So that is why I personally feel that this is important for you to be aware of. Now, I have deliberately spent relatively more time on the PR interval. Why? Because usually questions can be asked on this topic. I have also subdivided the discussion into conditions having short PR interval and prolonged PR interval. So a quick revision for you. Short was discussed with respect to Wolff-Parkinson-White syndrome and Lown-Ganong-Levine syndrome. Whereas when it comes to prolonged, the first situation I described was first degree heart block. I hope you recall that when it comes to Mobitz 2 heart block, we're not going to put it in this category of prolonged PR interval. In spite of that, right, it still belongs to heart block because conduction is not occurring. So in prolonged PR interval, definitely Mobitz 1 heart block will make a cut or will be able to enter. So will be complete heart block also, but not Mobitz 2 heart block. So do keep a watch on these minor aspects that I've highlighted. And subsequent to that, in the ECG, you will also be encountering the Q wave. Now, what does Q wave indicate? It indicates septal activation. It will fit into one small square in the ECG, but lots of time in the exam, they might actually ask you regarding deep Q wave. Definition of deep Q wave would be that it will be going out of one small square. Let me just highlight this. If this is one big large square, there would be 5 small squares, each having a duration of 40 milliseconds. Now I'm gonna draw a Q wave in slight yellow color. It fits into one small square. Now draw an abnormal one which is spilling out of it. The first condition having this is myocardial infarction. In fact, deep Q wave in MI signifies cell death, and this finding will persist for whole life of the patient. It's never gonna go back. Second scenario where you can get a deep Q wave especially present is hypertrophic obstructive cardiomyopathy, mainly the subendocardial ischemia component. And third one is important with respect to pulmonary embolism. You all have read this so many times, right? S1, Q3, T3. It basically means deep S waves in lead 1, deep Q waves in lead 3, inverted T waves in lead 3. Well, where do you get it? You get it in patients of pulmonary embolism. You get it in patients of acute cor pulmonale. This is a separate topic which has been covered in the pulmonology section, and you can go through that. But at the moment, I want you to remember this information, which is important. Conditions causing deep Q waves are the ones which have been enumerated at the particular aspect, MI, HOCM, and then it's going to be S1, Q3, T3. Subsequent to this, we will talk about abnormalities related to the QRS complex. For that, I want you to remember another information. Whenever in the exam they ask about QRS duration, there can be two possibilities, either narrow complex tachycardia or broad complex tachycardia. Whenever you read this word, narrow complex QRS tachycardia, I repeat the fact once again, the complete statement should be written, because otherwise a broad complex QRS can be present in multiple scenarios, even in bradyarrhythmias as well. Like for example, we talked about broad QRS even in third degree heart block. So when I say narrow QRS complex tachycardia present in a patient, it always signifies SVT, supraventricular tachycardia. I'll be describing various varieties of it like atrial fibrillation, atrial flutter, PSVT. Whereas whenever you read about wide QRS complex tachycardia, in those circumstances, it will always imply a VT. Ventricular tachycardia can actually be lethal and can even contribute to death in an individual. In fact, all of the arrhythmias are lethal, but when it comes to VT and ventricular fibrillation, they are relatively more common that you encounter, and therefore chances of death can be seen. Please remember the fact when I'm talking about sudden death, it's mainly gonna be either ventricular fibrillation or ventricular tachycardia. But if he uses the word sustained arrhythmia, if he says which is overall the most common sustained arrhythmia, then the answer is not to be given as what we have discussed at the moment. Answer is atrial fibrillation. So the next topic that I'm going to explain to you is atrial fibrillation itself, and one of the highlights of this topic is that SA node will no more be the boss of the heart. It will rather be having absent P wave. You can very well notice the characteristic twitching present in the current ECG that is being shown before you. So let's have a look at some important information for this arrhythmia. One I've already shared with you, the most common sustained arrhythmia. That means it can persist long duration, whereas when it comes to other tachyarrhythmias, they would be present as a sudden episode, and either the patient will survive or he will die. Only two possibilities. But atrial fibrillation, surprisingly, the patient may be well preserved. He might die later because of various reasons. Like for example, in atrial fibrillation, there could be clot formation in the left atrial appendage. So if he says, and I've discussed this in CNS topic also, what is the most common cause of embolic stroke? I repeat the fact once again. Overall, the number one cause of embolic stroke is the topic that we are studying, atrial fibrillation. But to make it sound sophisticated in the MCQ, he's going to write the word non-rheumatic atrial fibrillation. I want you to remember this question because embolic stroke / ischemic stroke is the commonest variety of stroke. The next statement I've already said, but still I need to do the honors, which is the overall most common sustained arrhythmia. Now the interesting thing is, whether he says what is the commonest sustained arrhythmia in a hypertension patient, whether he says commonest sustained arrhythmia in a geriatric age group per se, whether he talks about hypertrophic obstructive cardiomyopathy. Remember in HOCM, sudden death was ventricular fibrillation, but here the word is sustained, no? So even in HOCM MCQ, if he says sustained arrhythmia, it is not ventricular fibrillation. Ventricular fibrillation can't be sustained, man. Person will die within 4 minutes of onset of ventricular fibrillation because ventricles are twitching. No cardiac output, which will basically expose the person to risk of brain death, and most patients will never survive out of such kind of an event unless and until obviously a defibrillator is available, a trained medic is available, and he reaches the hospital in time. These are two important MCQs that I want you to remember for this topic. Now, before I go into more details of the ECG shown, I would like to give you a demonstration of how atrial fibrillation develops in a person, and usual important cause from exam perspective will always be beginning with the alcoholic patient. Because in cardiology, whenever you read alcoholic patient, like in GI, when you read alcoholic, you are always thinking about cirrhosis, portal hypertension, caput would say like that. Similarly, in cardiology, whenever you read about a person who, the question begins by describing having alcoholic patient, your thought process could be the examiner is trying to lead you towards dilated cardiomyopathy, and whenever heart is dilated, the structural damage can set up multiple ectopic foci, and these multiple ectopic foci can then result in either clot formation or they can result in twitching of the atria. Let me explain more details before you. The dominant pacemaker of our heart, SI node, is doing its job at the moment. It is firing at about 60 to 100 times per minute. That's the max firing frequency. I mean, upper limit of 100. Obviously, it can fire even more than that if there is sympathomimetic stimulation. But now I am showing in color green multiple ectopic foci generated in the left atria of a person of dilated cardiomyopathy thanks to long-term alcohol intake. These green dots that are shown before you can fire at a rate of as much as 300 to 600 beats per minute. I repeat the fact once again. There can be multiple ectopic foci present in the heart of this patient. That is usually on the left side we see them. And how do we know whether they're on the left? How do we map the heart per se? Then we have special studies that are called as electrophysiological studies, where we put special electrodes and map out the heart. We know how the current is gonna move inside the heart. So multiple ectopic foci in this case, how are they gonna discharge? How are they gonna fire? Has been studied with EPS, electrophysiological studies, and we have found that they can fire at a huge rate of 300 to 600 beats per minute. You can see SI node, poor fellow, only 60 to 100. These guys are gonna do 600 per minute. So obviously they're stronger, and the poor fellow SI node will now admit his defeat and will stop firing, which explains the fact that why is it written in a MCQ of atrial fibrillation absent P wave, because this guy cannot compete electrically with these ectopic foci. Now these ectopic foci will try to capture the AV node of the patient, and then we'll try to capture the bundle of his also, the left and the right fascicle, and we'll also try to make the ventricles beat faster. The problem in patients of atrial fibrillation is that it is the ectopic foci which are now become the drivers of the heart. And now I'll draw some mathematical calculations here where I will prove to you how heart rate in these patients can either surprisingly normal. You see, we all have vagus nerve in our body, and vagus nerve innervates the AV node. AV node anyway exhibits what is called as AV nodal delay, that is 0.1 second, and now I'm mentioning that AV node also has the capacity to block these impulses. You can see these green impulses which are coming from top onto the AV node, but the AV node says no, I'm not gonna let you through. AV node can be imagined like a goalkeeper, right? He's stopping a penalty shootout, so he's gonna say no, I'm not gonna allow you to score. So AV nodal block of 2:1 basically means that for every 2 penalty shootouts, one impulse, that is one impulse or one time the ball will be going behind, right? The striker will be able to strike a goal or will be able to make a goal, but one time this goalkeeper AV node will be able to bounce off the impulse. The message is like suppose the ectopic foci is firing at a rate of 400 times per minute. Huge value, 400. If 400 impulses are landing on the AV node, all 400 will not be able to go down. Right, I said 2:1 block means the goalkeeper slash AV node. AV node is also called as gatekeeper of the heart now. So I'm just changing that into goalkeeper of the heart. And what I'm trying to say is it is going to bounce off the impulses at a ratio of 2:1. That is, for 400 impulses that are going to land, all are not going to go down. As a result of it, the ventricular rate of the patient will not be 400. I'm just dividing 400 by 2 to say that the ventricular rate of the patient is at the moment 200 per minute, which is obviously definitely fast. So the vagus nerve will try harder, and therefore now I'm changing the AV nodal block to 3:1. It means that only 1/3 impulses will be able to go down out of 400. If 1/3, if I divide 400 by 3, now you can see that the ventricular rate will change to 133 per minute. Now the vagus nerve is more confident. Yes, I can block. You see, the penalty shootouts are coming fast, but the goalkeeper is able to block. So now if he is gonna do a 4:1 block, you can see that if you divide 400 by 4, this will become 100 per minute. Well guys, my objective is not to teach you mathematics. Please don't be bogged by it. What I want to teach you is that in atrial fibrillation, these ectopic foci, each one of them, they fire at a variable rate. For mathematical calculations, I had obviously, set the mathematical value of 400, but it can be variable. It can be 400, 420, 450. So because the ectopic foci, and listen to this part very carefully, because the ectopic foci are gonna fire at a variable rate, therefore the AV nodal block will also be variable. And if AV nodal block is variable, then the ventricular rate will also be variable. Why I explained this variability is because every time you read atrial fibrillation in a medicine textbook, he always says this word, irregular pulse. I've tried to explain to you why in atrial fibrillation is it written irregular pulse. And in case you missed it, I'm gonna repeat it again. I said the ectopic foci which are generated in the left atria of these patients due to dilated cardiomyopathy, structural damage, they fire very fast. They don't fire at a constant rate. That's the problem. They keep on changing their firing frequency. As a result of it, the AV nodal block, that is the goalkeeper, will also try to change the block. As a result of it, the ventricular rate will also change. And in fact, a very surprising observation is that in atrial fibrillation, heart rate can touch normal. 100 is upper limit of normal, no? Atrial fibrillation is a tachyarrhythmia in which heart rate can touch normal. If the heart rate is normal, the query of most doctors is, then why are you giving such a big description? I mean, if heart rate can touch normal, why patient won't be symptomatic? Well, I agree to the fact that if heart rate is normal, patient will not be symptomatic from the perspective of palpitations. But because at the movement atria will be twitching can contribute to stasis. Look at the words that I'm saying. I said atria not contracting, there's twitching implies that there would be stasis of blood in the left atria, and due to stasis there could be formation of these clots in the left atrial appendage, and any one of these clots, if they go into systemic circulation, God help this guy, he will develop stroke. Atrial fibrillation is dangerous even if heart rate is normal. Why? Because the clots which are formed in this condition. This explains why we start oral anticoagulation in these patients. Why it is important that atrial fibrillation patients, even if the heart rate is normal, they can still die because of the risk of embolic stroke, which explains my statement, the first one that I made in this topic. The most common cause of embolic stroke is non-rheumatic atrial fibrillation. So let me just describe this in a case-based format before you. This is a 40-year-old guy. He's a hardcore alcoholic. He needs a bottle of alcohol every day. And today it was maybe a marriage party in the family. So he and his friends are doing binge drinking. Now his friends and him are thinking that it's a very cool thing to do. In India, people will obviously, open the bonnet of the car, and then they're gonna sit on it and maybe start boozing and pass loose comments at passing by people. I mean, they're creating a nuisance at the moment, and they think it's a cool thing to do, but this is definitely a law and order problem. See, I personally would not have any issue with anybody drinking as long as they're not troubling somebody else, right? So I'm not saying that somebody should not drink, or I'm not trying to be a moral preacher. All I'm trying to say here is that if a person wants to drink, he should not create problems for others. This guy and his friends are too boisterous, they're causing problems. Now, this chap who was already, maybe creating some kind of a nuisance, he started feeling sick. He told his friend, I'm not feeling well. When his friend asked him, what's wrong, buddy? He just tried to signal with his hand like this that maybe his heart is beating very fast, because lots of time people will always not know this word palpitation. So he might just say that something is wrong with my heart. And then he started feeling dizzy. And then he passed out also. He became unconscious. And initially his friends were laughing over the fact that, oh, he consumed little bit of alcohol, he became unconscious. I mean, as guys would do, oh, his tolerance is so less. See, he consumed 2 pegs and he's down. But then one of the friends who was a little more, I would say, considerate, he realized that, this guy had only 2 drinks and suddenly he has collapsed. So we should take him to the doctor. So they bundled him up in the car and brought him to your casualty. And when you examine any unconscious patient, the first thing that you do is obviously take care of the vitals. When you check the pulse rate of this guy, the pulse rate was dramatically fast. But when you checked for the rhythm, you found that the pulse was irregularly irregular. In fact, guys, at this junction, I want to say that only 2 times will you read this word irregularly irregular rhythm. One, multifocal atrial tachycardia, MAT, which is discussed separately in the app Infairly if you scroll down in the lecture series. And second is irregularly irregular rhythm for atrial fibrillation per se. So those are 2 scenarios. I'll just put it in bracket at the moment. MAT, multifocal atrial tachycardia, and atrial fibrillation are the 2 scenarios. And we will also try to understand how do you differentiate them subsequently. Now, since I asked the nurse to check the blood pressure of this unconscious guy also, she said, sir, BP is unrecordable. So I said, okay, let me check by myself. Lots of time a nurse may not be as well trained as you, and she may not be able to record the BP when it is going to be like 60 by 40, 70 by 50. So you decided to check the BP by yourself. But this is dramatically a low blood pressure value, and he's having possible cerebral ischemia, and even he can have an irreversible brain damage due to low blood pressure also. So my objective next is to get the blood pressure back to normal. I need to know why is the rhythm irregular, and therefore I'm going to ask my medic to do a ECG in this guy. Now, when I do the ECG of this guy, though the ECG was already shown, I'm gonna draw it again. This twitching part may or may not be visualized by you. Sometimes I mean the ink blots on the paper, so that twitching part may not be visualized. But what you will definitely be able to notice in this patient will be that there will be a QRS complex, even a T wave, but you will not be able to see the P wave. You will notice every time there will be a QRS complex coming up, but that will be occurring without a P wave in the patient. That's the trouble in this case. And then the next problem that will come up is, again, I'll just highlight the fast beating of the heart, and a very characteristic feature that will occur in these patients in the ECG. I highlight once again, the twitching part may not be visualized, but you will still be able to pick up the ECG. How is what I'm trying to represent here. And that part is, guys, that in this particular chart, the RR interval will never be constant. You see, in all tachyarrhythmias, mark my words there, in all tachyarrhythmias, the distance between the R and the R wave will always be constant. But in these patients, RR interval will keep on changing, and in between, heart rate may be normal. Why? I told you, that's because thanks to the vagus nerve, the vagus is trying to be protective. It's trying to protect the heart. I mean, that's the basic function of the vagus nerve. It's working like a goalie. It's working like a goalkeeper, deflecting the penalty shootouts. For 400 impulses, it's saying 2 is to 1. Okay, 50% bounced off, only 50% going down, right? 3 is to 1, better performance. 4 is to 1, still better performance. So this goalkeeper is doing very, very good. But even if the heart rate is 100, the clots could still be there, go in the brain, and well, this guy could end up with a hemiplegia, quadriplegia. No big deal about it. So I'll just focus on the ECG that I shown before you earlier, and I want you to notice the fact here that if you look at the number of the large squares which are present between the R and the R waves, I'm just highlighting those large squares which can be easily deciphered by you, because lots of time I understand the resolution issues can be there. Now look at the huge disparity. It's obviously more than 3. It's about 3.5, 3.6. But I just want to highlight with help of these arrows that you can notice the huge disparity in the RR interval. I mean, the moment you get this huge disparity in the RR interval in the ECG, there are only two tachyarrhythmias which are to be thought of, guys. Whatever be the history given in the question, if in lead number 2, which is the rhythm strip given right at the bottom, they'll give you a 12 lead ECG in the exam, right at bottom will be lead 2. In lead number 2, if you ever are gonna get a irregular RR interval, it is a confirmed MCQ of either atrial fibrillation or multifocal atrial tachycardia. And I'll tell you one more hack how to go about it. If he's beginning with an alcoholic, it will always be atrial fibrillation. If he begins with a COPD patient, it will be multifocal atrial tachycardia. You can go through the multifocal atrial tachycardia part subsequently as well, but that's a good hack that works almost all the time. I got a question, irregular RR interval, begins with alcoholic, atrial fibrillation. Begins with describing a COPD patient, irregular rhythm, multifocal atrial tachycardia. That's the carry home message that I basically want you guys to understand. And now, since I've caught hold of the disease process per se, so I need to treat this guy. So let's look at what should we do in a person of atrial fibrillation per se. And this guy could be having it for a very long period. It is just the fact that symptoms became right now very visible, because when he will take alcohol, alcohol will suppress the vagus nerve. If the goalkeeper is intoxicated, he won't be able to stop the impulses, no? That is when the heart rate was increasing. You see, the vagus nerve will be suppressed by the intake of large amount of alcohol. As a result of it, I mean, the vagus nerve was, I said, responsible for AV nodal block. It was working like a goalie. Now the goalie is intoxicated. He cannot function optimally. So there will be more goals scored, and that is what is happening. Increase in the heart rate of this guy. The first and the foremost thing for management of all patients of atrial fibrillation is rate control, and that is what they always love to ask you. So your answer would be given as esmolol. Why esmolol? Why not longer acting molecules? Because BP is low, no? If the BP is very low and I am using some longer acting drugs, there will definitely be problems. So I can use esmolol, I can use verapamil. The basic point is, in this guy, the heart is beating too fast, so it is not getting sufficient time to relax. If there is going to be improper filling, if less will come in, less will go out also. So first and the foremost is rate control in this person using esmolol and verapamil. This will help this person regain consciousness, and then subsequently I will also be doing a echocardiography in the patient. Now I'll also tell you what are the criteria on basis of which oral anticoagulation should be started. But at the moment, first of all, I would like to highlight that what are the drugs that should be given to these patients to minimize the chances of development of embolic stroke. So the drugs which are available are novel oral anticoagulants, that is NOAC. The novel oral anticoagulants are rivaroxaban and dabigatran. They love to ask about these drugs and their mechanism of action in your exam, so you need to be rock solid with that. Like for example, I'll just highlight before you that rivaroxaban has an alphabet X present here, so this is gonna be a factor 10 inhibitor. When it comes to dabigatran, it has a T available here, so this would be a direct thrombin inhibitor. Obviously, there are various hacks to remember it, and you can remember or read about these drugs from the pharmacological domain as well. But at the moment, I want you to remember that whenever he will ask you about the anticoagulation part to be done in atrial fibrillation, instead of us answering warfarin, which was used when I was a student your age, answer novel oral anticoagulants. What is the problem with warfarin? You anyway know warfarin can contribute to a brain hemorrhage for which prothrombin complex concentrates would be required. You can note down a pharmacology based MCQ here. Though it is discussed elsewhere in the app also multiple times, the best drug for management of warfarin toxicity, especially like if the INR of the patient is in double digits. Now, let me give you a huge value of 20. I mean, INR of this guy is 20 times higher than the normal person. So if it is in double digits and the person is also having intracranial hemorrhage, is himself mentioned regarding possible posturing in a patient, unequal pupils developing in a patient, then I will be giving ready-made clotting factors, that is prothrombin complex concentrate slash frozen plasma. Plasma is frozen, no, so it may not be available immediately. Even if you get it from the blood bank, you'll have to thaw it. So in those circumstances, for warfarin toxicity, it is prothrombin complex concentrate. I highlighted why warfarin has not been talked about here is mainly because we are having safer drugs available. Now, once I have done these steps, then comes the role of what would be called as rhythm control. In rhythm control, I am trying to suppress the abnormal ectopic foci in the heart. I'll explain to this patient subsequently that there are multiple electrical current generating tissues in your left atrial appendage or left atria per se due to dilated cardiomyopathy. In those circumstances, we can plan out a surgery for you as well. We can put a implantable cardioverter defibrillator for you as well. But the first and the foremost point is we will try medically. You see, intervention comes later. First is medical management. Medically, I would like to now suppress these ectopic foci which are sending impulses down at a very high frequency. Therefore, in these patients, I am trying for what we can also call as chemical cardioversion. You see, one we have electrical cardioversion, that is DC shock, but in this case, I'm trying out a chemical cardioversion which can be written as rhythm control in the MCQ. Again, I usually find a lot of doctors not being able to answer or giving wrong answers to this question. Your answer would be given for the drug of choice as a class 3 antiarrhythmic, that is ibutilide. Instead of ibutilide, we can also use amiodarone. I repeat the statement once again. We can also use amiodarone. Amiodarone, guys, is a broad spectrum antiarrhythmic drug. Amiodarone is preferred in ventricular tachycardia. You have no pharmacology. Drug of choice for ventricular tachycardia is amiodarone. Amiodarone can be used for VT. It can be used for SVT also. SVT also, that is atrial fibrillation. But in the textbook, first ibutilide and then amiodarone is given. So yeah, amiodarone may be answer in some multiple choice questions. But if it is, if you have to choose between ibutilide and amiodarone, then obviously answer would be given as ibutilide. Now, unfortunately, in my patient, chemical cardioversion has failed. I have given ibutilide maybe even twice, 2 shots, no, not working. Then I'll obviously go the hard way, and the hard way is make these ectopic foci behave themselves. How? By electronically suppressing them. So we will now be going in for a electrical cardioversion in the patient, in which we will be delivering a DC shock. This would be a synchronized DC shock. I'm writing the word sync here to say that the computer will fire the impulse at the peak of the R wave. In subsequent arrhythmias, we will study regarding non-synchronized DC shock. But at the moment, I want you to understand in atrial fibrillation, we use a synchronized DC shock, and this will fire the impulse at the peak of the R wave because we want to suppress the abnormal contractility. The heart is not contracting properly. No, it is twitching. I want to suppress that abnormal contractility. And once I give the DC shock, the heart will relax. It will get filled with blood and then it will be able to rather contract normally because SN node will recapture the heart. See, SN node became silent because of ectopic focus. Now you have suppressed the bad guys. If you suppress the bad guys, the SN node will be back in action. It will be able to take over the cardiac activity once again. So a synchronized DC shock will do the trick here, and the intensity of DC shock that would be given here will be 200 joules biphasic. whatever value I tell you, after that I may or may not write the word biphasic every time, but it is implied it is always biphasic. When I was a student your age, we used to read about 360 joules monophasic or uniphasic, but at the moment you will notice all the models are gonna be not uni, but they're biphasic. There are various reasons for that. When we used to give this monophasic 360 joules, it used to cause superficial burns in the skin, it used to cause muscle necrosis, so CPKMM values used to get elevated. So we were always in a fix. Was CPKMM or MB elevated because after all skeletal muscle is there in the chest and there is cardiac muscle in the chest also. So much of current will damage both skeletal and cardiac muscle. So CPKMM, CPKMB both will get elevated. Now I'm wondering, is this CPKMB elevation because of MI? Or this is because of the DC shock that I gave. So nowadays, I mean, even if you don't remember this, guys, the bottom line is we now do not use monophasic DC shock. We nowadays use a biphasic DC shock, and 200 joules would be sufficient to suppress these bad guys, and therefore the person will be definitely able to recover. Now, at this juncture, I also want to tell you that if somebody is having a recent onset atrial fibrillation, though there is no such way of knowing it, but let us just create this ideal situation. Like somebody had atrial fibrillation developing for first time in his life 6 hours back. He's being admitted in the hospital for some other reason. And during the monitoring, it was found he has gone into atrial fibrillation. Thanks to the vagus nerve, thanks to AV node, heart rate is still being preserved. But if it is a recent onset atrial fibrillation, then there will be no clots formed, no? I mean, in few hours, clots will not form. It requires obviously a couple of days before the clots would be formed due to the continuous stasis activity secondary to the twitching part. The message is, if it is a recent onset atrial fibrillation, which was detected on routine monitoring, the patient was admitted for something else, then in those circumstances, I mean, there is no need for anticoagulation. And yeah, we also have investigation also, not transesophageal echocardiography. Now I'll tell you a practical problem. Suppose you did a transesophageal echocardiography and the report came as normal. Is it that the clots are not there, or is it that the clots are there but they're too small in size so echo is not able to see them? See, there can be two possibilities, no? If my transesophageal echo is normal because I am a healthy person and I do not have atrial fibrillation, if my transesophageal echo is normal, it means that I do not have clots. But somebody who's having atrial fibrillation, even if transesophageal echo is normal, there's a possibility that clots may be there but may be too small to be seen by echocardiography. So therefore he says that you cannot just rely on transesophageal echocardiography only to demonstrate the clots. Therefore, to resolve this problem, they have a special score, and this score is what I want you to remember, or is the objective of the discussion now. This score is very frequently asked with respect to. So I want you to remember this score, which is called as CHAD S2 VASC score, where the certain components which are present and would help you decide for oral anticoagulation. I repeat the facts once again. I said, guys, in a person with atrial fibrillation, if the clots are too small in size, they may not be visualized on echo. And transesophageal echo, I mean, if there is even clots in the left atrial appendage, the transesophageal echocardiography as an investigation may not be always available, especially at night time if the patient is coming. So I obviously need to see whether clots are there. No? By morning, the person will develop embolic stroke. So if I want to start oral anticoagulation, I need to have some evidence, and that is why the scoring pattern is there, which is called as CHAD S2 VASC score. Just look at the parameters here. Alphabet C would be standing for congestive heart failure, hypertension. Then is age of the patient. You can see that the scores are given. You don't need to remember the scores per se. What you need to remember is mainly the parameters. So just get the parameters right. CHAD S2 VAC. It is congestive heart failure, hypertension, age, diabetes mellitus, stroke history. Why stroke history is important is especially if he's having already a TIA event, if he's already had a previous history of stroke, then we will be giving a higher mark to this patient. That's again, I mean, I said scores are not important, but I'm just trying to tell you why is that parameter taken to be important. And older the patient, higher will be the chances of problems developing in the patient. VA would stand for vascular disease, or vascular, I would say, problems in the patient in the form of peripheral arterial disease. This could be like Burgess disease in the patient. Then SC stands for sex category. Alphabet, it was VASC. So alphabet SC stands for sex category, which is female. Please remember, only being a female is not a risk factor for development of clots in patients of atrial fibrillation. You obviously need other parameters also. So I'm not saying that sex category alone is sufficient for you to start anticoagulation in the patient. And you will also notice that age is coming two times here. Age more than 75, 65 to 74. Different marks have been given. So this scoring pattern is again used to decide for the need for anticoagulation anticoagulation, I'll just put the theory component here. If he says, how do you determine need for anticoagulation in a diagnosed case of atrial fibrillation? Because you by just evaluating the patient do not know when did atrial fibrillation start. It could have started couple of days back, and now when he consumed alcohol, that is when it really became serious and there was rather a deterioration of the patient. So first answer is transesophageal echocardiography, because if I can see the plots, great. But if not, then I have this scoring pattern. We'll practice once again: congestive heart failure, hypertension, age, ECG, diabetes, mellitus, stroke history. I'll just put that because that's important, previous stroke history. Then is vascular disease in a patient and sex category, gender being female. So this score helps you in evaluating whether you need anticoagulation or not. And the drugs I've already told you, you need to answer novel oral anticoagulants. Is there a possibility that ever atrial fibrillation will degenerate into ventricular fibrillation? Is it possible that all the 400 impulses will go down into the ventricles ever? Yes, if a person is having bundle of Kent. See, AV node has a decremental property. AV node is innervated by vagus nerve. So no chances in a normal person, in a person with a normal heart. But whenever there is a bundle of Kent, whenever there is an accessory pathway, then accessory pathway does not have any decremental property. So all the impulses can go down. So the only scenario where atrial fibrillation can degenerate into ventricular fibrillation is what I've just told you. Bundle of Kent present in a patient, there is a accessory pathway present. Accessory pathway does not have any braking properties. It does not have any decremental response per se, which explains the sudden deterioration developing in the person. I shall now be comparing atrial fibrillation with the next tachyarrhythmia on the agenda, that is atrial flutter, and I want you to notice some similarities and some differences as well. Well, first and the foremost is that in atrial flutter, there is a special circuit in the heart which contributes to the development of this arrhythmia, and the technical term to be used for that is macro reentrant circuit. Well, where is it located? It is located in the right atria. What I'm saying next is optional for you. I've just taught you the topic of atrial fibrillation. There I was saying the problem is in the left atria. And this problem in the left atria was of multiple ectopic foci which were firing at a rate of as much as 300 to 600 beats per minute. So in the exam, what he wants to see is, first of all, he wants to see that are you aware of these fundamental differences of the origin of these ectopic foci. And then is the discharge frequency, because in flutter the ectopic foci will fire at a rate of something between 240 to 350 beats per minute. In contrast, in atrial fibrillation, I was using rates of as high as 300 to 600. I taken an average value of 400 for calculation purposes. The next part of the discussion is critical and important. Listen to my words very carefully. When so many impulses are gonna land on the AV node, the AV node, by its inherent nature of gatekeeping properties, will try to exhibit a AV nodal block. On the right hand side in atrial fibrillation, because the firing frequency is very high, so AV nodal block will also be of the higher grade. I said if the frequency is higher, the AV nodal block will also be higher. So usually in atrial fibrillation, we might be having is a 4:1 block. And if I apply mathematics here, 600 divided by 4, the ventricular rate of the patient will be 150 per minute. For the left hand side, what I'm saying is, because of the fact that the frequency is relatively lower, because of this lower frequency, the AV nodal block will also be of the lower grade. I used higher frequency, higher grade on the right hand side. The goalkeeper is more aggressive because of higher frequency. Left side, lower frequency, lesser grade. If it's going to be 2:1 Blake, then in those circumstances, the ventricular rate of the patient will turn out to be 350 divided by 2. This will be 175 per minute. Please appreciate, I don't want to teach you mathematics. I just wanted to prove to you that how is it possible in the textbook that it is written that AV nodal block with respect to fibrillation is of higher grade, but the rate is lower. Because mathematics, if you look at it, no, the AV nodal block is of higher grade. Why? Because the goalkeeper is trying to be more aggressive. Left side, lower grade, he will be relatively relaxed. So lower grade implies that ventricular rate will be 175 per minute. And well, atrial flutter has a faster rate as compared to atrial fibrillation, guys. I proved that to you mathematically. How is it possible? Now we need to look at the ECG features. The ECG features of atrial flutter, I'll hand draw before you, will be these sawtooth waves. These sawtooth waves are originating with respect to this macro reentrant circuit. In fact, if he wants to incorporate a little bit of more anatomy, he might even use this circuit root. It is present around the cavo-tricuspid isthmus, that is the area in the right atria where the SVC is opening, and just inferior to that would be the tricuspid valve present. So that's where this abnormal current is generated, and it results in this abnormal firing of the heart. In the ECG, you will be noticing these sawtooth waves followed by a QRS complex, which might be relatively narrow. Then again, sawtooth waves followed by a narrow to normal duration QRS. I mean, the faster the heart will become, the QRS complex will become narrower. You will be able to elicit these sawtooth waves, however, not in all 12 out of 12 leads because the focus is right-sided, no? So don't be surprised if you're noticing these findings of sawtooth waves in lead number 2, 3 and AVF only. In atrial fibrillation, no problem. In atrial fibrillation, all 12 out of 12 leads because left side is well studied by the ECG. You will be noticing a QRS complex relatively narrow. T wave may or may not be present, or may not be, or may be buried, or may be hidden. I just try to symbolically show the fact that what is most predominantly present in all ECGs is the irregular heart rate of the patient. You can notice the huge difference. No, I mean the heart rate has suddenly jumped up fast, then has become normal. I did not say slower, I said it has become normal. So this kind of arrhythmia where heart rate can touch normal also is present only with respect to atrial fibrillation. Now we will talk about the treatment part. In atrial flutter, it is the same thing. So if we will ask you what is first line management, your answer is rate control. After rate control, because there is risk of pulmonary embolism, this time the clots could be in the right side of the heart, so they could land up in the lungs. In atrial fibrillation, clots were left sided, so they could go in the brain. So I was talking about in atrial fibrillation with respect to cerebral embolism. In fact, the first statement I made for atrial fibrillation was it will cause stroke. But in atrial flutter, it can cause pulmonary embolism, so anticoagulation. Then is chemical cardioversion. C stands for chemical cardioversion. The drug I taught you for chemical cardioversion for atrial fibrillation and atrial flutter is the same. What will you answer, guys? You will answer ibutilide. It is a class 3 antiarrhythmic molecule. And at the same time, I also want you to remember that if ibutilide is not given in the MCQs, then amiodarone can also be answered. But if all will fail, then you will go for DC shock. The DC shock that you're giving to the patient is electrical cardioversion. Here, I want you to remember that the intensity of DC shock for atrial flutter will be 25 to 50 joules. This is the lowest value of DC shock ever that I'm gonna tell you, and is one of the reasons why this is asked in the MCQ. Biphasic will be common. I have already told you currently biphasic. All models available in the market are biphasic models only by default. The message is that when it comes to electrical cardioversion per se, here the intensity is going to be the lowest of all the tachyarrhythmias that we're going to discuss, because every time I'm going to talk about 120, maybe 200 joules. Those are the routine values I'm going to say. But when it comes to atrial flutter per se, you will be answering it as 25 to 50 joules. I have deliberately compared the two so that you can get a better orientation, and that is what you need to do in the exam also, because when you read those questions, if they give you a case, you should definitely be able to pick up the clinical history. In atrial flutter, we'll be talking about the same kind of aspects of palpitations, then syncope, then possibility of even a bump on the forehead, a subperiosteal bleed because he fell down. But when you evaluate the person, the heart rate is going to be dramatically fast, and you will definitely be able to notice these very classical waves which are not going to be having the height and the duration criteria of the P wave. Because anyway, the boss here is definitely not the P wave. The current of the P wave is merging with the current generated from this macro re-entrant circuit, and as a result of it, well, the bad news is the person can deteriorate. In these patients, if the BP turns out to be very low, then if there's a delay in reaching the hospital, then these patients can unfortunately expire as well. An additional aspect that I would like to say towards the end of this discussion is, like I taught you, for delta waves are gonna be encountered in EEG also. He asked about sawtooth waves, and in the exam he did not say ECG, he said EEG. Couple of guys read it casually, lost a valuable mark. You obviously will be warned for that, as I've already explained it to you, or I've already sensitized you to it. Yes, guys, can you tell me from physiology, when are you gonna get sawtooth waves in EEG? The answer is REM sleep per se. I have said the next statement already, but just to reinforce that statement, delta wave has been discussed in ECG for Wolff-Parkinson-White syndrome, but delta wave in EEG, that's the word, guys, delta wave in EEG is gonna be encountered with respect to NREM stage 3. These are a couple of fact-based questions that I want you guys to remember over and above. And careful reading is obviously of paramount importance in the exam. This is over and above whatever we have discussed. I would suggest you for ECG and arrhythmias part one at this juncture. I mean, take a breather and then listen to the same data maybe at 2x and just scroll through the data once again, and especially focus on those parts of the lecture where I have actually hand drawn the rhythms. And I would like you to hand draw this with your hands also on a piece of paper or a glue stick and stick it somewhere so that you can look at the rhythms repeatedly so that your eyes are able to pick that up in the actual situation in the exam. Thank you so much for hearing me out, guys. Keep hammering, keep focusing till the wall breaks. I mean, I'll see you on the other side in a sense that once you qualify, I mean, you're gonna be all big smiles, and that I would say that's the pride that I feel when I talk to doctors who have cracked the exam, and when they come back and they revert to us, that's the real appreciation for me. Anyway, guys, at this juncture for you guys, I just want you to focus, and you're doing great. All of you are doing great. It is, don't get bothered by how many marks you got in a mock test. That keeps on changing on a day-to-day basis. Your job is to learn new facts on a daily basis. The more knowledge you have, more confident you will be. Thank you so much for your patience and hearing me out.